And today we're going to have neonatal hematology topic, that is on anemia, thrombocytosis, and we'll be talking on the blood products as well. So today's speakers will be Dr. Kumar S R Kumar from Hassan, and assistant professor at Hassan Institute of Medical College. So we would like to give a warm welcome to you. Welcome to you, Dr. Kumar.
Thank you, sir. Thank you, Krishna.
And we have next speaker, that is Dr. GANGADHAR. We welcome you as well, sir. VISHWANTH KAMOJI. So today's session will be moderated by Dr. Dinakar. Dr. Dinakar, sir, we welcome you as well. So I request Dr. Kumar to please start the session. Over to you, Kumar.
Thank you. At the outset, I thank NNF Karnataka for giving me this opportunity. So my topic today is how do you approach a neonate with anemia? So we should also overview. We are going to have one case discussion initially, just to have a basic thing. Then we'll have an introduction, then etiology, diagnosis approach, and then treatment. 16-day. A 16-day baby was, this is a case discussion just for good understanding. 16-day baby was admitted in NICU with a history of yellowish discoloration of skin and vomiting 2 to 3 episodes from day 1. There was no history of convulsion. There were high-pitched cry or arching. Vomiting from day 1 is non-bilious. There was no distension of abdomen. It contains only milk, and it is immediately after feeding. There was no history of constipation, clay-colored stool, dark-colored urine, or poor feeding. Coming on to antenatal history, the baby was delivered to G2P1L1 mother. It was a spontaneous conception. Married life was 4 years and born to non-consanguineous married couple. Mother blood group was O positive. She had regular antenatal checkups. There was no gestational diabetes, PIH, and she was only on nutritional supplements. So mother received 2 pints of the blood transfusion on 5th and 6th month for anemia. Her hemoglobin was 6 gram percentage. And birth history, baby was born by LSCS. It was indication of non-progression. Cried immediately after birth. Cried immediately after birth. Birth weight was 3.25 kilo and breastfed after within 1 hour. Family history, there was no history of jaundice or blood transfusion in the family, and elder sibling is 2 years and healthy. On examination, the pulse rate was 142, normal volume regular, respiratory rate was 34 per minute, saturation was normal, and CFT was less than 3 seconds. Anthropometry, weight was 3.2 kilos, length was 49, head circumference was 35.5 centimeter. Head-to-toe examination, child had icterus and was paler. There was no dysmorphic features, and on systemic examination was completely normal. So here we have a baby who presented with jaundice. So term baby, prolonged jaundice. So then what are the causes? So we'll investigate one by one. So we want to know the cause now. On investigation, hemoglobin was 5.1, hematocrit was 18.4, RBC was 1.5 million per cubic millimeter, MCV was 121, MCH 33, MCHC 27.7 gram per DL. Total leukocyte count was 17,310. Platelet was 7.5 lakhs. So all the hemoglobin was low here, and MCV, the RBC was 1.5 million. The hematocrit was also low. We got a peripheral smear done, which showed anisopoikilocytosis, macrocytic with severe hypochromasia, with good number of microcytes, oval elongated pencil-shaped cells. There was no inclusion cells, and normoblasts were 6 per 100 WBC. So that was also normal, and there are no parasites seen. So it had an impression of dimorphic anemia with leukocytosis. So mother blood group was O positive, baby blood group was also O positive. Renal function test and electrolytes were normal. Serum bilirubin was 13.7 with a direct component for 11.4, indirect was 2.1. thyroid was normal, G6PD was normal, vitamin D, B12 and folic acid was normal. Serum LDH was 863, which was slightly on the higher side. Electrophoresis revealed HbF of 74%, HbAs 27%. It was also normal. CT brain was done to look out for bleed. It was not there. So to summarize, it is a 16-day baby presented with anemia and jaundice with maternal history of blood transfusion in second trimester. There was no features of hepatosplenomegaly, no CCF, no dysmorphology. On investigation, retic count was on the higher side, negative KUMS, smear was suggestive of dimorphic anemia, and there was elevated LDH. So what do you think is the diagnosis? So this is just to stimulate ourselves before we go on to actual discussion of anemia. So now we will look at the flow chart. So very important. Here we know that there is hemoglobin is low. So we got a retic count which is on the higher side. So if it is on the higher side, that means what? We should get a KUMS test done. KUMS test was negative. We got it as a negative. And MCV we got, which was also on the normal side. So we got a peripheral blood smear done. So peripheral blood smear was suggestive of what? It was dimorphic anemia. So it was also normal. It was not abnormal. It was normal. So it was suggestive of blood loss. So with this, we'll go on for presentation. So neonatal anemia. So what is the definition of neonatal anemia? Hemoglobin or hematocrit concentration of greater than 2 standard deviation below the mean for postnatal age. There is no exact value for that. So the hematocrit is low or hemoglobin is low below the 2 greater than 2 standard deviation. That's what it says. So fetal erythropoiesis, as we all know, you can see the diagram here. It evolves initially in the primitive erythropoiesis starts in yolk sac. Until 10 weeks, the erythropoiesis occurs in yolk sac. From 10 weeks to 32 weeks, it takes place in the liver. And then subsequently from 32 weeks onwards, it starts in the bone marrow. So RBC production in extrauterine life is completely controlled by erythropoietin. It mainly produced in the kidney. Erythropoietin initially is also produced in the liver and then goes on for kidney. So hemoglobin, hematocrit and RBC count, they all increase throughout life. So size of and hemoglobin content of cells decreases, but MCHC will remain always same. So we should know what are the normal things. Fetal erythrocytes. What is the hemoglobin in the fetus? The left side shows the age at the gestational age. At 12 weeks of gestation, hemoglobin is around 8 to 10. 16 weeks it is 10, 20 weeks it is 11, 24 weeks it is 14, 28 weeks it is 14.5. Similarly, hematocrit. Hematocrit initially is low 33%, which goes on rising. At 34 weeks of gestation, it is 47%. Now, what are the normal values in newborn? At cord blood, hemoglobin is 16.2 plus or minus 3.6. Hematocrit is 46.66. And at 12 to 18 hours, the hemoglobin is 18. And then hematocrit is 49 plus or minus 4.8. At end of 72 hours, hemoglobin is 17 and hematocrit is 46.9. So we should also know MCV, MCH and MCHC. If you look at MCHC, the value does not change at all. Even if it is a cord blood at 12 to 18 hours, 72 hours, 7 hours, it is almost, if it is same, it is 34 only. So now we should know a few points about neonatal erythrocytes. Normal at birth, it is 5.1 to 5.3 million per millimeter cube in term. In preterm, it is 4.6 to 5.3 million millimeter cube in preterm. Lifespan at birth, for adult, we already know it is 90 to 120 days. In a term baby, it is 60 to 90 days. And in the preterm, it is 35 to 50 days. The nucleated RBCs are immature erythrocytes seen in normal newborns shortly after stress of delivery. They usually disappear by 4 days in term and 7 days in preterm. If they persist beyond 1 week, then it suggests that there is some pathology. Dysmorphology of RBC in term neonates. It is 3% seen in case of spirocytes and piculocytes compared to in preterms, it is 14%. So the rate of hemoglobin synthesis and RBC production decreases sharply during first few days after delivery due to decrease in erythropoietin in plasma. So we'll know this. During neonatal period, newborn leaves the relatively hypoxic in utero environment and they come into a different setting where there will be completely oxygen. So where is erythropoietin synthesized? So regulates, see this erythropoietin regulates production of RBCs in utero and birth. initially secreted in the liver and then goes on a third trimester to the kidney. At the end of gestation, the erythropoietin is at peak, and during the time of delivery, erythropoiesis occurs nearly 3 to 5 times because of this erythropoietin. What happens after that? At delivery, the PaO2 level increases. When the partial pressure of oxygen increases, obviously there will be decrease in erythropoietin production, resulting in decreased hemoglobin synthesis. So what happens to the RBC physiology at birth? So in intrauterine, what happens? There is hypoxia. Because of that, more and more erythropoietin. So more and more hemoglobin production, more and more nucleated RBCs, and their increased reticulocytes. After birth, because of increased PaO2, there will be decreased erythropoietin production, resulting in decreased hemoglobin production and decreased nucleated RBCs, and reticulocyte will be less than 1%. So what is, then we should know what is physiological anemia of infancy. See, when the baby takes first breath, what happens? Hemoglobin combines with oxygen, saturation increases. So there will be more and more delivery of oxygen to the tissues. So there will be no hypoxia at the tissue level. So, and then there is also switching from fetal to adult hemoglobin, which has more oxygen affinity. So because of this, then there is no hypoxia, the EPO productions get suppressed. And because of this, there is suppression of erythropoiesis. Hemoglobin decreases. What happens until the, so what happens is until say 8 to 12 weeks, the oxygen level, hemoglobin level, the hypoxia will take place until 8 to 12 weeks, until baby can tolerate. After that, hypoxia will be detected by renal and hepatic sensors, where there will be production of erythropoietin, then erythropoiesis, and then increased hemoglobin production. This is a benign condition and does not need any treatment. Then what is anemia of prematurity? So it is an exaggerated response seen in preterm during transition. Physiologic anemia in preterm is more profound and occur earlier than physiologic. So what are the main causes for anemia of prematurity? One, there is inadequate RBC production and short survival. As we already know that the survival of premature RBCs is only 50 to 60 days. So there will be more and more breakdown. Second, there is blood loss because of sampling. And there is also nutritional deficiencies of iron, vitamin E, vitamin B12 and folic acid. That's why the anemia of prematurity occurs. So there is, even in added to this, there is inadequate synthesis of erythropoietin due to hypoxia. So initially liver is a predominant source, then the insensitivity it goes on for. So and the liver is also immature in prematures. So there will be more and more breakdown of erythropoietin, and there will be decreased hemoglobin production, and there will be decreased nucleated RBCs, and there will be decreased reticulocytes. So because of this,
Kumar, Kumar, I think the net got affected. ಒಂದ್ಸಲ ರಿಫ್ರೆಶ್ ಇದು ಮಾಡ್ಕೊಳ್ಳಿ, ರಿಫ್ರೆಶ್ ಮಾಡೋಣ. Singh?
ಹಾಂ ಸರ್.
ನೆಟ್ ಅವ್ರದ್ದು ಬ್ಲಾಕ್ ಆಯ್ತು, ಸ್ಟ್ರಕ್ ಆಗಿದೆಯಾ?
ಮೇ ಬಿ ಸರ್ ಅವ್ರದ್ದು ಅದೇ ಕರೆಂಟ್ ಗಿರೆಂಟ್ ಹೋಯ್ತು ನನಗೆ.
Okay. Just call. I've called Dr. Kumar. I think we just lost him. He's going to join us back. Just give me a minute. Yeah. Yeah, he'll be joining in a while. I think if Kumar is taking time, I request Dr. Gangadhar MIRJI to start the presentation. Dr. Gangadhar. Hello.
Yes, sir. I'm starting.
Yeah. Please start the session.
Dr. Prashant?
Yes, sir.
Please, so many people wants to join. You are not allowing them to join, dear. Please, can you tell, because more than 80 requests have come to my mobile. You are not allowing them to join. Please, can you tell them, because many people are from Orissa, Rajasthan, Manipura, Mizoram, Kerala. Please, can you allow them to join?
Shall I start, sir?
Sir, start, sir. Gangadhar, sir, start, please, sir.
Okay, sir. Thank you. Good evening, everyone. Myself, Dr. Gangadhar MIRJI, consultant neonatologist, SN Medical College and Shanti Hospital in Bagalkot. I'll be discussing regarding the neonatal thrombosis and DIC in this webinar. I'm very thankful to NNF Karnataka for giving me opportunity. Yes, neonatal thrombosis and DIC, again, controversial statement, not uncommon. Yes, we see neonatal thrombosis in tip of iceberg, how we are seeing corona cases, only each one case, how 10 cases are there, same as each one neonatal thrombosis we diagnose, there are 10 cases undiagnosed. The objective of this study is why neonatal thrombosis very common in neonate, why they will prone, epidemiology, risk factor, and the types of thrombosis, what are the clinical presentation, how we can diagnose, once you diagnose, how you have to evaluate, what are the therapeutic options, and I'll discuss some common specific conditions. In the last, DIC. Why the neonates they come? Yes, the hemostatic potential of the healthy neonate. Either it is term or a preterm. If it is not having any critical issue, is neither promoting the hemorrhage or a thrombosis. Yes. But the developing hemostatic system, definitely it is vulnerable to the disruption. Like how the developing brain is very much vulnerable like asphyxia, same as developing hemostatic system. So combined the critically ill neonate with the physiological distinct neonatal hemostatic system, it fulfills the criteria for Vico triad. And there is certain difference between the older children and the adult compared to the neonatal hemostatic system. There is both quality wise and the quantity wise. Yes, this is a Virchow triad. Yes, like vessel injury with the most common is catheter and asphyxia. Stats is again catheter, congenital heart disease, sepsis, shock, dehydration, summer dehydration. We are seeing the cases I will discuss later, and the hypercoagulability in both sepsis, IDM babies, maternal lupus, or even inherited or congenital thrombophilia. So, comes to the what is the difference between neonate and the adult? Comes to the primary hemostasis, which is component of vanillary factor and the platelet count. In adult and neonate, yes, platelet count is both have normal, but the condition is the neonatal platelets are hyporeactive. But this is very much compensated by the high level of vanillary factor. Next comes to the coagulation factor. Coagulation factor, vitamin K dependent. Most of coagulation factors are less compared to adults. Is almost around 40 to 50% compared to the adult. But the fibrinogen and factor 8 are equal in both neonate and adult. Anticoagulant factors, yes, all are reduced except the alpha-2 microglobulin. Fibrinolysis, yes, plasminogen is less, but the activator, plasminogen activator inhibitor is almost same or slightly more than the adult. So come to the epidemiology. The incidence being the 5.1 per lakh, and comes to the NICU admissions, the neonatal intensive admissions, it can be vary from 2.4 to 6.8. Like German register, Netherlands, Canada, the most of register it's look into, it's range from around 2.5 to 6.7. Again, I told like a corona, how is a tip of iceberg, because the autopsy they have done with UVC or UAC in situ during the death, almost it showed 20 to 65% with in situ catheter, they will have thrombosis. And we are seeing the almost 3-fold increase in the thrombosis. Why? Because we know the more critical babies are admitting in the ICUs and the more invasive procedure, and we know the awareness is increasing, and very much important is very accessible to the ultrasonograph. And some study from the Italian registry, around 55% are venous thrombosis, around 29 are arterial thrombosis, 12 are around 16% are intracranial thrombosis when they studied around 75 events. Some studies says male or female equal, but this study shows male are represented more cases. Comes to the risk factor. Risk factor, we have the maternal, neonatal, and the catheter associated risk factor. In maternal, mainly infection, PPRM, diabetes, and antiphospholipid antibody syndrome. In neonate, especially sepsis, NEC, polycythemia, asphyxia, and congenital heart disease. In catheter related, very important. Is it the catheter duration? What duration? Is more than 6 days, malposition, and the blood products. If you give blood products to the UAC, and in JSS College, Mysore, they have done study around 30 cases of thrombosis. No, only in UAC. They found out 3 cases with thrombosis when they infused through calcium gluconate through the UVC. Those baby, they had thrombosis. And come to the inherited thrombophilia was present in 33% cases of early onset venous thrombosis, and even they are very common with the renal vein thrombosis. Most common is factor V Leiden mutations, protein C deficiency, protein S, antithrombin deficiency, antiphospholipid antibodies. Next, what are the types? One is arterial thrombosis and venosus. Arterial thrombosis, we have perinatal stroke, other is atogenic arterial thrombosis, and the Spontaneous arterial thrombosis. In venous, we have catheter-associated thrombosis without involvement of cardia, with involvement of cardia, and other is renal vein thrombosis, portal vein thrombosis, and the cerebral vein thrombosis. Yes, how they can present? I already told most of are in hospital in NICU. They may be asymptomatic, and only is I told renal thrombosis and cerebral vein thrombosis can be presentation. They can present with those two conditions. Most of there are other thrombosis are in-house. Can be most of them found incidentally on imaging of other regions. Signs and symptoms, they depend on the where the thrombus location. This next slide is, please concentrate. It's very important. Everything it is there. See, early, if it is arterial, what you have to look at the extremities. Is it pale, cold? The pulses are weak or absent? Is it blood pressure reduced? These are the, if arterial thrombosis is there in extremity, you will see these signs and symptoms. In intestine, the intestinal necrosis occurs. So feed intolerance and NEC. Kidney, there is a elevated blood pressure. If aorta involved, definitely blood pressure difference in the arm and leg. Some case reports are there. They're presenting like a critical aortic arch syndrome. So there is a difference, failure. So they are in-house, not from outside. Whenever there is a already admitted case, they have signs. When the catheter are there, they diagnose like this. CNS, apnea, seizures, lethargy in case of perinatal stroke. Lung, they'll have pulmonary embolism like distress and the right heart failure. Comes to the venous, they'll have swelling, pain like deep vein thrombosis, hyperemia, intestine, portal vein when they're involved, the liver function is impaired, and there may be splenomegaly. In kidney, see, they can have hematuria, proteinuria, abdominal mass. That's one presentation of renal vein thrombosis. In inferior vena cava involved, then again they can have renal vein thrombosis. Renal vein thrombosis can lead to inferior vena cava thrombosis also. And they can have, due to pulmonary embolism, they can have respiratory distress also. And again, CNS, cerebral vein thrombosis, again they present with seizure, lethargy, apnea. And comes to the late, these are the venous collaterals, limb growth reduced, and portal vein, if involved, there may be portal hypertension. They come with the GI bleed, and in kidney involvement, they can present with the convulsions secondary to the increased blood pressure. Aorta, they may be post-thrombotic syndrome or a varicose veins. CNS, there is developmental delay, cognitive impairment, cerebral palsy. And lung, there may be RVH. Now, once you know what are the symptoms, how you have to diagnose? Yes, diagnosis by ultrasound, which is very feasible, accessible, and it is non-invasive, and no radiation. It's almost diagnosed around 60 to 70% of cases. If it is not diagnosing, yes, you are still suspecting thrombosis, then you can other modality like contrast venography, CT, MRI. So once we diagnose the thrombosis, then how to go about it? It depends on what type of thrombosis, what is the severity, is it we have to going to start the treatment or a wait and policy. So the basic investigations, even for evaluation of the thrombosis or the starting the treatment, what is required is complete blood counts. We have to see the platelet and the prothrombin time and partial thromboplastin time and the fibrinogen levels. So these are the ranges, because we can't compare the test with the adult. What are the in our labs, what they will give, all outside is adult lab, adult values reference range. So we should have in NICU what are the ranges in preterm and the term baby. So again, the laboratory evaluation continues when if neonate have significant thrombosis, early thrombosis, if they have renal vein thrombosis, if there is no much risk factor, like no catheter related, if there is a family history, then comes with we have to do antiphospholipid antibody panel, protein C activity, antithrombin, factor V Leiden, and homocysteine and lipoprotein. And if only one important this one point is here is Okay, you can order the test. These tests, okay, not easily done in all the settings. One thing, cost with this, and once we got the report, is it how you have to compare? You have to compare with the reference range. What you have abnormal values, then you have to repeat after the 4 to 6 weeks, or you can do parents if they are heterogeneous. So next comes is the therapeutic options. What therapy? Yes, there is always wait and see the policy, and is it anticoagulation required, or a thrombolysis, or a both, or last option is the thrombectomy. So comes to the specific conditions. In specific condition, common things are venous thrombosis. Yes, venous thrombosis is related to the central vein lines. Sometimes they can we can see in the spontaneous, like in venous thrombosis seen in the renal vein, inferior vena cava, or superior vena cava, or the brain, because we seen the cerebral vein from how like that. Presentation, most of them asymptomatic, detected incidentally. There may be presentation like catheter is not working. One more is there is a swelling or the color change. The data from multi-center study, like again quoting the same 75 neonatal thrombosis, the venous thrombosis in 41 are venous thrombosis. In that 31 presented with, in that edema was 50%, limb discoloration was 34, abdominal mass was 10, and line dysfunction 7. The remaining are asymptomatic. So this is a of a deep vein thrombosis. See the color change, edema. Then once you diagnose, how you have to treat. The before treating, what are the long-term complications? Yes, there is a collateral circulation, chylothorax, portal hypertension, post-thrombotic syndrome, and diagnosis by the ultrasound. The treatment again depends on the, is it presence of clinical symptoms, location, and it is a thrombosis, stagnant or a propagating. So once you have a the central vein associated thrombosis in the vein, is it high risk? What is meant by high risk thrombosis? High risk thrombosis is compromising the organ or a limb. So it is very much compromising, means we have to start thrombolysis with commonly used is a tissue plasminogen activator. So we have to give that's maybe 6 hours or 12 hours or 24 hours, should be followed by low molecular weight heparin. If it is only occlusio, but it is not a high risk, so you have to start low molecular heparin. Anytime if it is resolves, okay, stop. It is present, they may require around 3 months. If it is non-occlusio, just wait and watch, but the continuous monitoring should be there clinically and ultrasonographically. So one is the thrombosis in right atrium, because whenever the cardiac comes, yes, definitely it is life-threatening. Yes, this is a life-threatening, is associated with the most of them central vein catheter placement. Yes, presence and all. If murmur is not there, yes, one murmur, an auscultation, heart failure, it can present with failure, respiratory distress. There may be persistent sepsis, which is not improving. Already you are in meropenem, vancomycin still not improving. There may be one isolated thrombocytopenia. So that's why the USC abdomen and the cardiac sometimes is very helpful. So this is the picture showing the thrombus in the right atrium. So again, once you know that the thrombosis is there, so what we have to do? Again, here high risk thrombus. What is meant by high risk thrombus? If it is more than 2 centimeter and obstruction to the flow and pedunculated, and there is a associated with hernia, failure, yes, definitely we have to go to a treatment. That again, thrombolysis and followed by low molecular weight heparin. In only that is without high risk, yes, we have to start with the low molecular heparin. Again, we have to do the ultrasonography. If the thrombus is resolved or not, depends on that. We have to give the treatment. If it is very small, we have to wait and watch. Again, repeat ultrasound at the, less than 3 days. If thrombus is extended, again we have to start heparin. If it not extended, again follow. So next comes to the cerebral vein thrombosis. Cerebral vein thrombosis can present immediately after birth or a first week of life. They present with again any CNS symptoms like convulsions, apnea, agitation, or sometimes it may be infection as a presentation. the most studies shows like it's more of hemorrhagic infection, around 50 to 60% of neonate. I already mentioned the inherited thrombophilia present in 15 to 20% of CVT. So we have to work up for inherited thrombophilia in CVT without risk factor. Mortality is 2 to 24. So again, disability like epilepsy, cerebral palsy, and cognitive impairment. So I'm not going to detail, but once you diagnose, yes, if there is hemorrhage, wait, and supportive treatment should continue. And again, we have to monitor if no hemorrhage, but progression of thrombosis, yes, we have to start heparin. If there is no evidence of hemorrhage at initially, so we have to start heparin. These babies require prolong around 6 to 8 weeks of treatment. Yes, this in Shanti Hospital, it's admitted around 2 days back. It's referred from periphery. Not baby is not improving. Not improving means yes, baby is not feeding. Even they're giving sepsis is not improving. Then on examination, it was lethargic. Heart rate was 140, respirator was 60 on admission, but SpO2 was normal 96, CO2 was normal. But see, the important is habit of checking the blood pressure because we neglect the blood pressure. See, blood pressure, sick baby. Yes, it is a sick baby. What should have? Blood pressure should be low, but this blood pressure was high. It was almost 100 by 60. So it is more than 90 percentile. So on examination, we found out abdomen distended. Probably we thought of liver is enlarged. And there is a hematuria. See, you can see the hematuria, and the lab sepsis screen was positive. CRP was 12, platelet count was 1.3 lakh, and sodium was 118, potassium was high, urea is 76, creatinine was 2.9, and albumin is 2.2, and urine was RBCs around 15 to 20, albumin is 3+, pus cells around 5 to 6. Why? Again, renal insufficiency was there. And lab was sepsis was there. Urinary potassium initially 6 hours was okay. Again, it gone into anuria, and we got an USC bedside. We are done. There's somewhat enlarged kidney. We found out enlarged kidney. So again, get done by a radiologist. It showed enlarged kidneys, the loss of corticomedullary, almost the whole infarction of left kidney, and almost upper and middle fold of right kidney. So the creatinine is increased from 2.9 to 3.5. Potassium 8, so anuria for more than 12. Then we started PD. Yesterday only we done procedure that. So what we are discussing, nothing but renal vein thrombosis. Triad, yes, abdominal distension, abdominal mass, with or without thrombocytopenia, hematuria. Okay, probably this case may not be inherited, probably sepsis that leading to thrombosis. So renal vein thrombosis, it approximately 10% of, it accounts for 10%, most prevalent of non-catheter related incidents. Yes, 2 per 1 lakh population. Predisposing, already I told, sepsis, shock, polycythemia, infant of diabetic mother, CHD, and perinatal asphyxia. One of the study that almost they studied 271 patients from 13 case series. The presentation, even that renal vein thrombosis presentation can be intrauterine, 7% of cases. Most of them presented, almost 70% is presented less than 3 days. So, and between 3 to 28 days, around less number of around 1/4 cases. Most are term baby and male predominance. What our case also seeing male only. The findings are as hematuria, thrombocytopenia, palpable mass, but triad you will see in classical triad only 13 to 14% of cases. Most are unilateral, involvement of left more, already in our case also left more enlarged compared to right, and thrombus extension IVC seen in 14%, 44%, adrenal hemorrhage like complication 15%. The risk their studies is asphyxia present in 32, and IDM in 8, and dehydration is 2%. Already mentioned thrombotic disorders found in around 43 cases. So once we know how we have to diagnose, the minimum criteria is if it is micro or macro hematuria, or with abdominal finding of enlarged echogenic kidney with loss of corticomedullary differentiation. That is the minimum diagnostic criteria. The complication already adrenal hemorrhage, extension, hypertension, renal failure, renal atrophy or death. So this is the picture showing left kidney with the lack of contrast in the left side. So this is the absence of color in the mean right renal vein. Here the absent diastolic, the reverse diastolic flow in the main renal artery. So literature review, around 39, one is 59, recent Marks et al. 43 cases, they treated with low molecular weight, heparin, and tissue plasminogen activator, warfarin. See the almost this one, whenever they're involved, whenever requiring the treatment, the most they will go into atrophy or even bilateral atrophy, and some require nephrectomy, renal failure. The prognosis is poor. The management, yes, supportive care. If it is no impairment or no extension, yes, supportive care like dehydration, correct dehydration, sepsis, treat the sepsis. If it is extension, require anticoagulation. If it is bilateral, require anticoagulation. If with renal failure, yes, initial thrombolytic, then followed by anticoagulation. See one more case. Yes, I am neonate, I am discussing, but still I am put the 5-year-old boy. Yes, he's presented with periodic emergency room with one of the episode, like only first episode of bleeding, blood in the vomitus. Yes, on examination, vitals normal, maybe the pulse rate may be high because of one vomiting, blood, abdominal just spleen is just palpable, hemoglobin, yes, anemia is there, platelet count normal. As a bleeding, we know PTA-PT we have done, it is the normal range. But one clinching factor here is the birth history. Yes, it's a NICU graduate, preterm, 1.2, 5-year. Yes, probably it may have lines. So what I am discussing, nothing but portal vein thrombosis. It is the most common, extrahepatic portal hypertension. Estimates, again, 1 in 1,000 live birth. Risk factor, sepsis, swampolitis, extended transfusion, and most important is longer duration. If it is more than 14 days, wrong place, especially if you place the veins at the low flow, especially in hepatic veins, the chances of thrombosis is more. And most cases I told, asymptomatic in the neonatal period, that's why they are asymptomatic, growing well, 1.2 kg, now 5 years, he's weighing around 15 kg, means he is well grown. So that's why most of their asymptomatic. The recanalization occurs almost 75%. If there is partial thrombi, occlusive thrombi, almost it is near to 50%. So this is ultrasound grading. If it is non-occlusive, grade 1. If it is occlusive with single branch, grade 2. Grade 3, if it is occlusive with involvement of parenchymal changes, these they will go into liver lobe atrophy. This is a thrombus. The complication, acute, less likely, there may be hemorrhagic ascites or liver necrosis. Chronic, yes, more than the portal hypertension. Part of the lobe atrophy is common, is there asymptomatic. Portal hypertension, the age of presentation, maybe one study they quoted 5.3 years, around 5 years. Some they mentioned 3 years. So whenever we diagnose the portal hypertension in the early life, we have to follow up to 8 to 10 years of life. Most of the resolution 30 to 70% cases, and it takes around days to month. Actually, there is no evidence to start the anticoagulation therapy, and prevention is the best because less UVC, proper position, and whenever not required, please remove early. Okay, I finished with the venous, comes to the arterial. Arterial, yes, UAC now because too many premature babies are admitting, and again with whenever the mass with BPH are admitting, require definitely umbilical vein catheter for monitoring the BP or ABZ. Okay. So the most important thing in USA related thrombosis is it may be asymptomatic. Most again can be catastrophic, signs of severe ischemia to the organ dysfunction. Again they come with the coolness, poor perfusion, blanching of the toe and the limbs, even buttocks. So next slides I will tell how to monitor these cases. Hypertension, they can develop with or without the renal failure, NEC, and spinal cord infarction. Presentation can mimic the severe aortic coarctation. So Come to the peripheral artery occlusion. Yes, there is a depends. There may be present with diminished perfusion, pulses, prolonged CRT, pale extremities. They may manifest as skin lesions or as just petechiae because of embolic phenomena. Diagnosis by Doppler ultrasonography. Severe thrombosis is extremely long-term arterial insufficiency can impair the growth of the affected limb. So this is an example showing the brachial artery cannulation, the distal involvement of thrombosis, all the limbs, and even there is a necrosis, the tip. So how to manage? Minor thrombi, mild symptoms, just remove the UAC. If it is large, non-occlusive, just remove the catheter, start the anticoagulation with low molecular or unfraction. May be required for around 3 to 4 weeks. That large, yes, there is a compromise. So catheter is still present. Try for local thrombolytic therapy through the catheter. If the catheter already has been removed, is obstructed, consider the systemic thrombolytic therapy. If both are failed, is already the compromise of limb, so thrombectomy may be tried. So one of the important, while doing the procedure, while placing the UAC or peripheral arterial line, there will be sudden the spasm, peripheral spasm. So what happens? What we have to do is, we have to warm the contralateral extremity for 15 minutes. If there is no reduction, continue the closely and symptoms return, remove the catheter. What you have to do is the local application of nitroglycerin comes, it should be dosed in 4 ml per kg, and most of them they'll resolve. How you have to prevent? Yes, we'll infuse 0.5 to 1 unit per ml of unfractionated heparin at the rate of 0.5 to 1 ml. But still controversy. Some studies shows yes there is a reduction. Some studies saying there is no reduction. Cochrane 2005 they say it's no reduction of thrombosis. Yes, there one question mark. High umbilical artery lines we have to prefer between T6 to T9. Low they will associate with thrombosis. If it is baby is more than 1.5, better to go for peripheral arterial line. And most important, what I am telling next is how to monitor whenever the UAC is present. Serial examination of the lower extremity for the color, pulses, perfusion. Should mark me and concordance of upper and lower extremity BP. Check for the hypertension and the urine output. Careful urine output monitoring. Urine for the both the micro or gross hematuria. Any difficulty in flushing or withdrawing blood. If you monitor this, okay, you can make early. You can attempt to remove the UAC as early as possible. So next, what we will discuss is the neonatal purpura fulminans. It also comes in neonatal thrombosis. Yes, it is a very much rare, life-threatening condition with DIC and hemorrhagic skin necrosis. Onset can be immediately at birth or may delayed up to 6 to 12 months of age. Most commonly caused by the congenital deficiency of protein C and S. Sometime maybe the conjunctive coagulopathy, maybe severe sepsis, some other causes are there, and presents with the extensive ecmosis or a venous and arterial thrombosis, especially in the injured part. We had this case around 8 months back, last August it was admitted, around 1 month of age that presented with these lesions. Baby was intubated, now extubated with sand, but baby succumbed at 3 months of life. The protein C level was very low. We started whatever the unrecommended all treatment what is required for that baby. So laboratory wise, there is definitely the evidence of DIC, that is platelet low, PTA PTT prolonged, D may have a high, fibrinogen be low. Again, the protein C and protein S activity we have to do, but it's again question mark. What level is normal at that age? Again, for confirmation, definitely genetic testing is required. Again, the treatment, maintain the platelet count more, fibrinogen more than 1 gram. If suspecting severe sepsis, treat aggressively with IV antibiotic and underlying cause. The fresh frozen plasma required every 12th hourly by 10 to 20 ml per kg, or cryospecified is available. That is also good. Protein C concentrations is not easily available. The other two are available. The bracket there, Baxter company, Ceprotein and Prosectel is available. And dose is initially we start with 100 units per kg followed by 50 units per kg every 6 hourly. The main aim is to maintain the protein C activity at 50 units per deciliter. When the protein C concentration not available, there is, if liver transplant is helpful, always they require the maintenance therapy with the warfarin. As one more case, this admitted in our unit SNMC last week, presented on 15 days of life, born by normal delivery with irritability, not passed during 12 hours, birth weight 3.1, and examination present weight was 1.7. See, almost 45% of weight loss. On examination, baby was irritable, poor respiratory effort, severe dehydration signs were present. ABG, acidosis, pH was 7, sodium was 186, the skin also duffy feeling, urea was 380, so creatine was 11, on CBC platelet count was just 37,000, and PTA-PT was prolonged. So dehydration also can cause, severe dehydration also can DEC. This one example I am giving here. So disseminated intracellular coagulation. This is a well-defined clinical situation and laboratory evidence of procoagulant activation, fibrolytic activation, inhibitor consumption, and the biochemical and clinical evidence of end organ damage or failure. So it can be infectious or hypoxic ischemia. Hypoxic ischemia can occur intrauterine or during the birth process or the postnatal. We have seen DIC, severe birth asphyxia, HS stage 3. We have seen the DIC, so many cases more with DIC. There may other causes, hepatic, metabolic, or a vascular malformation, even RDS, NEC, they can cause DIC. Diagnosis again, platelet is decreased, PTA-PT prolonged, fibrinolytic decreased, D dimer increased. One PS study, there is a fragmented RBCs. Management, yes, aggressive treatment of underlying cause, supportive, transfusion plasma, cryophosphate, platelet to maintain the adequate hemostasis. So last is the guidelines for choice of treatment. Already I mentioned, I will skip this slide. Small or symptomatic, weight, large occlusion, we have to treat. Massive, yes, thrombolysis or thrombectomy. So anticoagulant, yes, low molecular heparin, we can use low symptomatic or symptomatic. What is available here is enoxaparin, because this is very good pharmacokinetics. Subcutaneous, we can give low molecular weight heparin, and BD doses, and no, not required, not associated HIT, heparin-induced thrombocytopenia. And doses preterm is high, 1.7, term is 1.5. Always should have basic investigation CBC, PTA, PDT, but at baseline anti-factor 10 activated level 4 hourly after, and again after the second dose, and regularly monitor the platelets. Again, unfraction the heparin, most important in this thing is, because this important is factor clearance is very fast in neonate. Its action is depend on the anti-thrombin levels. So anti-thrombin levels, sometimes it's to augment, we have to transfuse the FFB. And most important is HIT, especially rare in neonate compared to adult. But more is important is one dedicated line is required for this unfraction heparin infusion. The dose is 75 units. In over 10 minutes, maintenance 28. In preterm, we'll use around 50 units, 40 to 50. And maintenance is 10 to 15. The monitoring is again important, and 4 hour loading, and then each change in the dose we have to monitor. Again is the recombinant tissue plasminogen activator, where you will use mainly in the limb or life-threatening thrombus. The dose is 0.1, maximum 0.5. You can use infusion over 6 to 12 hours or maximum 24 hours. You should have basic investigation before starting, CBC, APT, PT, fibrinogen, D dimers daily. Important is you have to rule out intracranial hemorrhage, require the daily scanning, and transfuse FFB daily to maintain the fibrinogen more than 1 gram per liter, and sometimes require platelet also to maintain more than 50,000. In critical L, you may maintain around more than 1 lakh. So there are some contraindication. That's why some very much contraindication are there. Sometimes it is life-threatening. thrombectomy, this advice, the main absolute contraindication is there is any CNS surgery or a severe asphyxia injury in less than 2 days, active bleeding, invasive procedure like within 3 days, convulsion within 48 hours. These are the absolute contraindication. Relative, yes, 50,000 fibrinogen more than 1 gram per dl or 1 gram per liter or 100 mc. INR is more than 2. There is a severe coagulation deficiency, hypertension. These are relative, but you have to weigh the risk and the benefit. Thrombectomy, yes, it is case of life and limb threatening arterial venous thrombosis. When there is the antithrombic, absolutely contraindicated. Microsurgical technique with thrombosis in patient with peripheral artery done. Studies are limiting, but very in neonate they will have very small caliber of vessels in neonate. Recannulation occurs very frequently whenever the undergone procedure. The newer things, yes, there are some anticoagulants include the factor activated 10 inhibitors. They're less studied and they're not still not used in neonates. One indirect thrombin inhibitor like ergotroben, they used especially when the patient with high risk of hyper-induced thrombocytopenia, they can use in ergotroben. Thank you.
Dr. Gangadhar, excellent talk. Beautiful talk.
Thank you, sir.
think so in my lifetime, DIC
I'm not audible, sir.
regarding the DIC, regarding the thrombosis and how to treat. Yes, you work. I know. Simply after the talk, looking like that. From my heart, I am telling you. I think so. All the participants also. I am telling they will definitely tell you. You have gone through almost more than many references. You have put it beautifully done. Really, I am very, very happy, sir.
Thank you, sir.
Really happy. And now we will ask many questions are there. People have sent many questions to us regarding the thrombosis as usual, because you used warfarin and so many things. Now we will take all the questions later. We will take all the questions later. Whoever raise their hands, please, we will definitely give you a chance. Please type it and send to us. Send to us. And Dr. Prashant. Dr.
Yes,
Prashant.
yes, sir. Yeah.
Okay. You have allowed everybody to do the, type their questions and send here.
Yeah, they can send it to us. There is no problem. One request for all of them: if you have not renamed yourself, it is like iPhone, iPad, like that, or Galaxy, please rename yourself by your name. That is easy for us, so that people who are not relevant, we can remove it immediately. So I request all of the participants who have not named properly, please rename yourself, or you send a message, I'll rename it. If you cannot do it on your own.
Okay. Number one, and I think so there are more than 40 members. 40 members, in spite of requesting, they have put only Galaxy. Other thing, that is the reason we are not able to take them. 40 members are there. I requested them. No problem. We will go to the next talk. Dr. Kumar.
Yes, sir. Sir.
He's ready with the presentation, sir.
Okay. I think so. Your internet is now correct.
Yeah,
your internet is now correct.
Yes, yes.
Okay. Sir, over to you, sir. Dr. Kumar, please.
Thank you, sir. Sorry for there was some interruption in the internet. So initially what we discussed was when we had one case presentation, which was a nice one. And then after that, we told how to approach an anemia. After that, we discussed about physiology. Now we'll go on to etiology. So what are the causes for anemia in a newborn? So it is either because of blood loss, or because of decreased erythrocyte production, or because of increased erythrocyte destruction. So one by one. So what are the causes for blood loss? It can occur before delivery, it can occur during delivery, or it can occur intracranial. So what are the causes if it is before delivery? It can be because of feto-maternal hemorrhage, it can be because of feto-placental hemorrhage, or twin-to-twin transfusion. And during delivery, it can be because of placenta previa, abruptioplacenta, malformation of umbilical cord, velamentous insertion, vasa previa, umbilical cord rupture, aneurysm, and hematoma. And if it is because of internal bleeding, it can be because of intracranial, cephalhematoma, intraventricular, subgaleal, intra-abdominal, retroperitoneal bleed. Or it can be iatrogenic also. which because of phlebotomy. Then the second causes is decreased erythrocyte production. It can be in the bone marrow, it can be because of infection, it can be because of nutrition. So what are the causes in bone marrow? One is Fanconi's anemia, another one is Diamond-Blackfan syndrome. Infections, we have parvovirus B19, HIV, syphilis, CMV, and rubella. Nutrition, it may be because of iron, folate, vitamin B12, vitamin C, and vitamin E deficiency. Then next is increased erythrocyte destruction. It can be because of immune hemolytic anemia, where we have Rh isoimmunization, ABO, minor blood group incompatibility, SLE, autoimmune hemolytic anemia. It can be membrane defects, hereditary spherocytosis, elliptocytosis. It can be because of RBC enzyme defects. Most common are G6PD and pyruvate kinase. It can be because of hemoglobin disorders, that is thalassemia syndromes. It can be because of vitamin E deficiency. It can be once again because of infection, anemia of prematurity, DIC, and inherited metabolic disorders like galactosemia and osteoporosis. This is a huge list of causes of anemia in neonates. First, one by one, where there are only 3-4 points regarding this. Blood loss. It accounts for 5 to 10% of all cases of severe anemia. It can occur before, during, or after delivery. Usually follow fetal blood loss or obstetric complications or internal hemorrhage. Iatrogenic anemia seen in preterms due to repeated sampling. So most of them are asymptomatic. The symptoms appear only when more than 20% of the total blood volume is lost. Infants are asymptomatic in chronic blood loss also, except in pallor. The lab, what does it suggest? It shows only normocytic, normochromic anemia if it is the hemoglobin is 9 to 12, and if it is 5 to 7, it shows microcytic hypochromic anemia. The treatment is iron supplementation. So we'll come back later regarding the treatment aspect. So how do you differentiate acute blood loss or chronic blood loss? Both will have pallor. Acute blood loss will have all distress signs like tachypnea, poor peripheral perfusion, hypotension. Whereas chronic blood loss, they have hepatomegaly, ascites, and hypochromic microcytic anemia, reticulocytosis. Those things we have to differentiate, associated with cardiac failure also. Then because of iatrogenic cause, anemia secondary to blood sampling, very common. We've seen in NICUs, usually in premature children. 1 ml of blood we take is equal to 1% of total blood volume. We should always remember. And if we take around 8 to 10 ml in 1.5 kilo baby, so it will be around 8 to 10% of total blood volume. To avoid this, blood collection should be recorded. That is very important. Then how do you approach? If the anemia is because of blood loss, so first we do a retic count, normal or high. If it is high or normal, we go for Coombs test. If it is positive, then it comes because of destruction. Or if it is normal or negative, then comes your MCV. MCV normal or high or low. Low means chronic blood loss. If it is normal or high, you get a peripheral smear done. If it is also normal, it is because of blood loss. If it is abnormal peripheral smear, they suggest there are structural defects. So this is very simple flow chart. Then the decreased production. So as we know, decreased production is mainly because of either bone marrow problem, one is Fanconi's anemia and Diamond-Blackfan syndrome, or it is because of infection or nutrition. So what is Fanconi's anemia? It is autosomal recessive, result in progressive bone marrow failure. The progenitor cells in the bone marrow are hypersensitivity for certain glycoproteins such as interferon gamma. They result in premature apoptosis and eventual hematopoietic failure. They present as macrocytic anemia with reticulocytopenia and pancytopenia. So what is Diamond-Blackfan syndrome? It is mainly congenital disorder of the bone marrow suppression, mainly because of failure of erythropoiesis alone. They present as macrocytic anemia with reticulocytopenia. Etiology is unknown. It is believed to be result of defect in the stem cell differentiation into erythroid cell line. Now, what are the acquired causes? I already told infection. That is parvovirus B19 is the most common causes, most common virus, and other things are syphilis, HIV. Nutrition, iron, copper, folate, vitamin B12, vitamin B6, A, C, E. Now, what are the causes? The next one is increased destruction. In that, the first point is immune mediated. What is immune mediated? What happens is, whenever the fetal RBC bearing surface antigen, they are exposed on maternal RBC, enter into the maternal circulation, they stimulate a humoral response in mothers. So these IgG production will occur, they cross the placenta and enter into the fetal circulation. They also coat fetal RBCs, which will be targeted by reticuloendothelial system, and they will be removed from the peripheral circulation. The most common examples are Rh isoimmunization and ABO incompatibility with minor blood group incompatibility. Rh isoimmunization is a protein on erythrocyte comprised of several antigen sites, C, C, D, E. So which D is most significant. Those who lack D antigen on their erythrocytes are termed as Rh negative. So what exactly will happen? They are not, they will not affect first pregnancy. The subsequent pregnancy will be affected, and the first pregnancy baby will be normal. Only sensitization occurs in first pregnancy. The frequency is around 5 to 15%. So initially in first pregnancy, there will be leakage of fetal RBCs into the maternal circulation, and sensitization, there will be production of antibody D. This attachment of maternal antibodies, they went to Rh positive fetal RBCs will occur, and there will be destruction of the antibody coated fetal RBCs, resulting in anemia with severe hyperbilirubinemia. ABO incompatibility, this affects from first pregnancy also. It is most common here. This occurs only if the mother is O positive and babies are A and B positive. So they are present with minimal hemolysis, then mainly due to paucity of A and B antigen binding sites on fetal RBCs. So membrane defects. Defects in RBC membrane and cytoskeleton, they result in abnormal shape of the RBCs, which is also abnormal. So they are once again attacked by the reticuloendothelial system, and they removed from the peripheral circulation. Most common are hereditary spherocytosis and elliptocytosis. So hereditary spherocytosis is an autosomal dominant condition, and 20 to 30% are autosomal recessive, and there sporadic is also seen. So it is mainly defect in the attachment of spectre into RBC membrane. So because of this, what happens? The shape of the RBC will be small, so they result in spherocytes. They are fragile and non-deformable. So because of this, erythrocytes are prone to lysis and targeted for removal. So diagnosis, how do you diagnose this? One, there will be positive family history. Two, the child presents with jaundice, and non-immune mediated hemolysis will be there. And on smear examination, spheroid sites are predominantly seen. That's how we come to the conclusion that it is a child with hereditary spherocytosis. Next, hereditary elliptocytosis, it is also autosomal dominant condition because of the defect in various structural proteins. RBC with spleen as elliptical in shape, they are unstable, not deformable, hemolyzed by reticuloendothelial system. So diagnosis is by peripheral smear and family history. Now we will come to the next part, is enzyme defects. So G6PD and PK are the most common deficiencies. G6PD, which is an X-linked recessive disorder. So G6PD is active in pentose phosphate pathway of erythrocyte, resulting in production of NADPH. This is responsible for detoxification of free radicals and hydrogen peroxide within RBC. Whenever there is G6PD is decreased or absent, there will be accumulation of these damaging agents, resulting in cell degradation and membrane injury, resulting in hemolysis. How do you diagnose? Diagnosis is once again by peripheral smear. Hind's bodies in the smear is diagnostic of G6PD deficiency. Next, pyruvate kinase deficiency. It is autosomal recessive disorder, responsible for generation of ATP, adenosine triphosphate. Deficiency results in decreased cellular energy production and premature cell death. This results in hemolysis with hyperbilirubinemia, which might require exchange. Now we know hemoglobin disorders. These are slightly rare. We already know that it is mainly because of deficient or absent in production of one of the globulin chains. So it can be alpha thalassemia, it can be beta thalassemia, or combination of both. And the last one is sickle cell anemia. So during birth, so these are the different hemoglobins at different ages and the percentage of them in the cord blood. We have embryonic, fetal, and adult hemoglobins. So Gower 1, Gower 2, Portland, then fetal are BARTs and HbF, and adult hemoglobin we have HbA and HbA2 respectively. So these are uncommon causes of anemia in neonates. Erythrocytes of newborn has 60 to 80% of HbF, 15 to 40% of HbA, and less than 1% BARTs. So any deficiencies of alpha or beta chain results in formation of unstable hemoglobin, resulting in hemolysis. So the most significant is where all three genes are deleted, resulting in BARTs. So that results with microcytic hemolytic anemia, which can present with high drops. So this also we know sickle cell anemia, where there is replacement of glutamic acid with valine at 6th amino acid on beta globin chain. So this resulting in sickling, and any hypoxia will go on for sickling. This is also very rare. So this is most important chart which can lead us to the diagnosis. Whenever this has already been discussed, whenever we have anemia, first we'll get a retic count. If it is low or high, if retic count is low, it suggests that there is some bone marrow problem where there is decreased production. If it is high or normal, we will get Coombs test done. If Coombs test is positive, that means there is increased destruction because of immune hemolytic anemia, ABO, RH. If it is negative, we will get MCV done. MCV, if it is low, it is because of chronic blood loss or thalassemia syndromes. If it is normal or high, if then get a peripheral blood smear done. If it is normal, then it is mainly because of blood loss. If it is abnormal, that means there is abnormal shapes. So that results in we have all hereditary spherocytosis, erythrocytosis, all those things will come into picture. So how do you treat this? The first and foremost is iron supplementation. So American Academy of Pediatrics recommends all preterms, they should receive 2 to 4 milligram per kg of elemental iron per day and should be started after 2 weeks of postnatal age. Actually, there is a lot of debate on this. Previously, it was said that it should be started after 4 weeks of gestation, 4 weeks postnatal age. But now recent, they have come with this one saying that it can be started at 2 weeks of age. There was an RCT in which the birth weight less than 1.3 kilos, the early iron supplementation of 2 milligram per kg, it was increased to 4 milligram per kg in children where the hematocrit was less than 30% was started. And when was it started? When the feeds reached 100 ml per kilo. That has shown that there is a reduced requirement of PRBC transfusion in these babies. So it is a significant one. Cochrane review, there was randomized as well as quasi-randomized trials on enteral iron supplementation and preterm and low birth weight infants, suggesting that decreases, it showed that it decreases iron deficiency as well as iron deficiency anemia after 2 months of age. However, it also said that there is insufficient to conclude on the effect of iron supplementation on the growth, neurodevelopment outcome or adverse effect. They say that iron has to be started, but what happens later for the neurodevelopment outcome, it was not studied. So now, transfusion, very important. There are a lot of issues with the blood transfusion of PRBCs. So what is the goal of transfusion? One, restore or maintain oxygen delivery without increasing oxygen consumption. So transfusion practice many units that they have their own protocols for transfusion. So decision to transfusion is based on low hematocrit and clinical manifestations. So most of the institutes, they use guidelines which use hematocrit, clinical status, and sometimes age. There is also the PIN study, Kirpilani et al. Demonstrated transfusion threshold in extremely low birth weight can be moved downwards by 1 gram per day without increasing in death of major neonatal morbidity. So Cochrane, they have reviewed, and there are results of 4 RCTs with total of 614 infants. They compared restrictive versus liberal transfusion threshold in preterm, and there was no significance in difference of mortality or morbidity or neuron developmental outcome was noted. So they suggest it should be liberal, not restrictive. Now, when we say word liberal, what is the amount of volume that has to be transfused? Transfusion volume in neonates, they range from 50 to 20 ml per kilo. Not much studies are done regarding optimal volume that has to be transfused. But most of them standardly they say 15 ml per kilo. And that there are a lot of studies done. One small study of 30 transfusions in 13 neonates was done, weighing 500 to 1.5 kilos. That is 10 versus 20 ml kg, 20 ml plus 10 ml to 20 ml per kg was compared. And the authors reported that use of larger volume results in higher post-transfusion hemoglobin without negative respiratory effects and decreases multiple transfusions. So this study says that you can use the transfusion at the rate of 20 ml per kilo. And there was also one large observational study where with the 312 transfused premature infants less than 32 weeks found 50% increase in total transfused volume which prolonged the next transfusion. When we use 20 ml per kilo, it increases the total transfused volume by 50%, which can prolong the next transfusion. However, further trials are required to study optimal transfusion volume in preterm. So there are a lot of studies on this, and few studies support 20 ml per kilo. Next, who should be the donor? So because the preterm babies, they require multiple episodes of transfusion. So everyone have the same opinion that it should be single donor product. See, most of the things, what happens is the concern is here. So when the blood has been given, so we have to make it into multiple aliquots. Prepare it 50 ml. So give in the same blood donor, the baby should receive from the same donor. So it should not be from the multiple donors. That's what it says. Then leukocyte filtration. So what is leukocyte filtration? This is mainly to prevent the concentration of leukocytes. So very, very important. See, leukocyte depletion or reduction is done to reduce the concentration of leukocytes less than 5 into 10 to the power of leukocytes per unit of RBC. Leukocyte reduction, they help in preventing one non-hemolytic febrile transfusion reactions, HLA alloimmunization, and transmission of leukotropic viruses like CMV, EBV, and HTLV1. So transmission of intracellular viruses such as CMV are diminished by this using this leukocyte depletion filters. Next important, what is irradiation? What are we going to do with irradiation? So they are done mainly to inactivate donor T cells. This is mainly done to prevent graft versus host disease. So these blood components must be irradiated with a dose of 25 to 50 gray, that is 2,500 to 5,000 rad. Once irradiated, the blood has to be used within 24 hours. Then storage. Most of the times when you go to the blood bank, most of the people say, no, it is not fresh, it is old. Is there any study regarding that? So that is also very important. Long storage versus fresh blood. So long storage theoretically increases the risk of infection due to immunomodulatory effects, decrease the oxygen delivery to the organs and tissue, and induce a greater inflammatory response. So there was an RCT. The recent RCT was done in 380 babies in very low birth weight with no significant differences was found between the groups of infants transfused with RBC stored less than 7 days old compared with the RBC stored so more than 7 days old. So that's what the study says. So then now we'll come what. So we have seen in transfusion, what are the issues of transfusion. Now we'll go with what are the guidelines for transfusion. There are two guidelines. One is for preterms as well as term babies. If the preterm is on assisted ventilation and if it is less than 28 weeks old, more than 28 days old. FiO2 requirement, if it is more than 32 or if it is less than 30. Hemoglobin less than 12, PCV less than 40, or hemoglobin less than 11 or PCV 0.35. So then we have to transfuse the baby. RBC transfusion may be considered at higher threshold than the above for neonates with hypovolemia. So any baby on CPAP, if the hemoglobin is less than 10 or PCV less than 30, or if it is more than 28 days, hemoglobin less than 8, PCV less than 25. If the babies are breathing spontaneously, FiO2 requirement is more than 21%, then hemoglobin less than 8 or PCV less than 25. Or baby is breathing well in room, hemoglobin less than 7 or PCV less than 20%. So these are the indications for transfusion of PRBC in preterms. Next, in term babies, in a newborn with evidence of respiratory distress, transfusion is required for hematocrit less than 35 to 40% with clinical evidence of pallor, tachypnea, hypotension, inadequate perfusion. In the newborn without evidence of respiratory distress, transfusion is required for hematocrit less than 30% in the first week of life or in an infant requiring surgery. Tachycardia, tachypnea, significant apnea or cardiomegaly on radiograph, or poor weight gain with hematocrit of less than 30%. These are the criteria in term neonates. Next, how do you prevent all these things? How do you prevent anemia in newborn? And first and foremost is delayed cord clamping. So very important. There are several RCTs have been done regarding delayed cord clamping. So this RCT mainly it is done in preterms as well as terms also it has been done. So in preterms, so what do you mean by delayed cord clamping? It implies we should wait for at least 30 minutes, maximum 2 to 3 minutes after birth before clamping the cord. In preterm, it reduces need for PRBC, that is transfusion, improves circulatory stability, and a reduction in the rate of IVH and NEC. So this the RCT came to the conclusion with this. In term babies, a recent Cochrane review was done in which 762 neonates were involved. Beneficial effects of whether there was any good effects with the delayed cord clamping, but it was not proven. So higher hemoglobin will be there at birth, and there is improved iron status at 3 to 6 months of age. But babies requiring RBCs is too small. That's why there is no need to do delayed cord clamping in term babies, but it should be done in preterm babies. So, and there is also another effect where because of the delayed cord clamping, there was increase in phototherapy because of hyperbilirubinemia, which jumped from 2.7% to 4.4%. Next, what is milking of cord? It is an alternative to delayed cord clamping. It implies massaging the cord and allowing the umbilical cord blood towards the infant. This is faster and might be preferred during resuscitation. So there was an RCT involving 58 preterm infants and compared the effect of DCT to cord milking. It was shown that there was no effect. There was no differences were seen in hemoglobin levels or number of neonates needing PRBC transfusion. Another RCT was done comparing umbilical cord milking to and there was a control in which there was 36 and 39 for control, showed a trend towards the reducing need of RBCs in cord milking group and resulting in higher hematocrit as well as reduced IVH. Still, there are a lot of studies has to be done to prove this. Then, how do you reduce this iatrogenic blood loss? Most of the babies in NICUs are sick and which needs regular sampling. The use of microanalysis, smaller amount of blood for testing, indwelling lines with probes for IV or arterial measurement, these decreases transfusion. It is very, very important that reduce the blood taken for the lab, then the amount of blood which will be lost will also be decreased. So you should always reduce this iatrogenic blood loss. Next and foremost, erythropoietin, very, very important one. This was in 1987, the first clinical trial of erythropoietin in adults with end-stage renal disease was demonstrated that the erythropoietin treatment was associated with increased hematocrit and reduction in RBC transfusion. So then they thought whether it can be tried. So there are two timing strategies were employed in the erythropoietin trials. That is early treatment and late treatment. Early treatment, that is before 8 days of age, which was employed to prevent anemia prematurity, and late treatment after 8 days of age. That is, the protocols were designed to treat anemia prematurity and decrease PRBC transfusions during convulsions. Several studies investigated the role of erythropoietin in reducing transfusion. However, systemic reviews and meta-analysis failed to show clear benefit for early or late use. Major need for transfusion in preterms is in first weeks of life where there is no benefit of erythropoietin. In addition, concerns were raised about ROP, about after the use of erythropoietin. Conclusion. So the Cochrane review also showed that early erythropoietin administration reduces the use of RBC transfusion and the volume of RBCs transfused. These small reductions are of limited clinical importance. Donor exposure is probably not avoided in most studies, including infants who had received RBC transfusion prior to the trial entry. Means even after the using erythropoietin, there were some patients which already had ROP stage 3. So that also is very important. They concluded that due to the limited benefits and increased risk of ROP, early administration of EPO is not recommended. Evidence is lacking for all the possible neuroprotective role of erythropoietin in preterm infants. Thank you. And the second topic.
Dr. Kumar?
Sir.
Hello, Dr. Kumar?
Sir.
Excellent.
I'm hearing you, sir.
Okay, is it over, Kumar?
Sir, one more presentation is there on polycythemia.
Okay, dear. Please continue. Continue. Good. Continue. Dr. Prashant?
Yes, sir.
Okay, please, can you announce if any questions regarding the anemia in a neonate? Anemia, hello, if any questions, please tell them to post it, dear.
Yeah. I mean, few questions we have got. So I request all the participants, if you have any doubts, queries, please post your questions in the chat box. We'll be able to access that. And if you have not if you're not named yourself completely, please rename yourself. So it's easy for us to identify all of you. Thank you. Yeah, over to you, Kumar.
Okay, my second topic is on polycythemia. So once again, we'll start with a case presentation to make it more interesting. Baby of Pooja Venkatesh was a twin delivered normally. Twin one was birth weight was 2.1 kilo and the birth weight of the second twin was 2.2. Baby at 12 hours was delivered well, everything was fine, shifted to mother side. At 12 hours of life, baby was found to be plethoric and decreased activity, was shifted to NICU. So this was the picture of the two babies. So at 14 hours, the twin one has hemoglobin of 11.5 gram and the PCV was 39%. Twin 2 hemoglobin was 24 grams percentage with PCV of 74%. So identical twin exhibiting twin-to-twin transfusion syndrome, which we have seen there. So babies were admitted in the NICU, started on IV fluids 20 milligram extra we started. So CBC was done after 24 hours, which showed hemoglobin of 25.6 and hematocrit was 73. Serum bilirubin was 12.2, warranting phototherapy. Persisting high hematocrit, the partial exchange was done at 46 hours of life. Post-exchange, hematocrit dropped to 65% and the replacement fluid use was normal saline. Baby was started on direct breastfeeds from day 3 of life, received phototherapy up to 6 days. There was no documented hypoglycemic episodes and was discharged on day 7. And the hematocrit was done, which was 60%. So overview now, what I'm going to discuss here. What are the important terminologies we should know, definitions we should know, what are the introduction, physiology, incidence, what are the factors that influence neonatal hematocrit, etiology, classification, pathophysiology, effects and complication, lab diagnosis, treatment, and prognosis and recommendations, and conclusion in the last. So now we should know 3 terms. What is hyperviscosity, what is hematocrit, and what is polycythemia. Hyperviscosity. It is a condition in which blood is not able to flow freely through arteries because of decreased fluidity. Also defined as a viscosity above the 2 standard deviation of the mean. In these, the artery gets blocked due to many RBCs, WBCs are proteins in the bloodstream. So what affects viscosity? One is hematocrit is the most single important factor which results from increasing circulating RBCs, and plasma viscosity, where there will be high, because of higher plasma proteins, there will be more viscosity, especially fibrinogen. Then the third one is RBC aggregation. It occurs in areas of low blood volume. Then there is deformability of RBC membrane. So these are the important factors which affect viscosity. Viscosity is very difficult to measure. It is measured by Wells Brookfield cone plate microvesicometer. So relationship between viscosity and hematocrit is almost linear and up to 65% and exponential thereafter. So then what is hematocrit? It is the proportion of volume of blood that consists of RBCs calculated by automated analyzer. We can roughly estimate by hemoglobin into 3. So hematocrit, it is more accurate than plasma PCV, as PCV includes small amount of blood plasma trapped between RBCs. Next, what is polycythemia then? So most researchers define polycythemia as hematocrit more than 65% when obtained from a large free-flowing peripheral vein. So what the proper definition is presence of venous hematocrit more than 65% or venous hemoglobin concentration in excess of 22 gram per dl. Hematocrit is approximately 3 times the hemoglobin concentration in gram per deciliter. So after knowing the definitions and various terms, we should know why are we discussing about polycythemia. It is very important. Polycythemia and increased hematocrit is associated with hyperviscosity. As the viscosity increases, there is impairment of tissue oxygenation and perfusion and a tendency to form microthrombi. So if you look back at this diagram, the polycythemia and hyperviscosity, which results in microthrombi, and which net results in hypoxia, hypoglycemia, and acidosis. They cause significant damage. If these events are left just like that, they cause damage to the cortex, kidneys, and adrenal gland. Hence, this condition needs urgent diagnosis and prompt management. That's why the neonatal polycythemia is very, very important. Why this occurs? This occurs as a result of increased red cell mass with a decreased or normal or increased plasma cell volume. So physiology also we should know. Hematocrit usually peaks at 2 hours, then drops at 6 hours of life to 68%, and then becomes steady at 12 to 18 hours, and then 24 hours. So these changes are mainly caused by transudation of fluid out of intravascular space. So if you look at this diagram, initially at birth it is very high, then it goes down. At 12 to 24 hours, it remains stable. So incidence is around 1 to 5%. Increases in babies with IUGR and SGA babies, increases in 15% in SGA compared to term babies. So what are the risk factors? Neonates born at high altitude, their chances, they have the possibility of getting this polycythemia. Maternal smoking, they increase by 2.5 times. Infants born by LSCS has lower hematocrit than by vaginal delivery, and infants subjected to delayed cord clamping carry 4 times greater risk. So what are etiological factors? It is a multifactorial, involve 2 mechanisms. One is passive and active. Passive is because of erythrocyte transfusion. Active is because of increased intrauterine erythropoiesis. So what are the causes? Erythrocyte transfusion. So it can be because of delayed clamping of umbilical cord, uncontrolled or precipitous delivery, intrapartum hypoxia, twin-to-twin transfusion, maternal-fetal transfusion. Then active causes, placental insufficiency, preeclampsia, hypertensive disorders, other vascular problems, maternal hypoxemia due to cardiac or pulmonary disease, drugs, smoking, high altitude, post-maturity. And then disease associated with the fetus, LGA babies, maternal diabetes, Beckwith-Whitman syndrome, endocrine disorders like CAH, hypothyroidism, hyperthyroidism, and chromosomal anomalies where there is trisomy 21, 18, and 30. What exactly happens? Acute fetal distress and peripartum hypoxia, they result in transcapillary leakage of plasma. There will be increased blood flow from plasma to the fetus, increased plasma volume and erythrocyte. So how do you classify? There is another way of classifying this based on the volume status of the plasma. Either it is normovolemic, hypervolemic, or hypovolemic. So normovolemic polycythemia, condition where the normal intravascular volume is normal despite of increase in the red cell mass. So they result from increased RBC production due to placental insufficiency and or chronic intrauterine hypoxia. The examples are IUGR, maternal PAH, and discordant twins, maternal diabetes mellitus, prolonged intrauterine tobacco exposure, and post-maturity. Hypervolemic polycythemia occurs when higher than average blood volume is accompanied by an increased red cell mass. Acute transfusion to fetus such as maternal fetal transfusion, twin-to-twin transfusion. Then hypovolemic polycythemia. It occurs secondary to relative increase in number of erythrocytes to plasma volume. The main causes are intravascular dehydration. So what exactly happens in polycythemia? Why all these things happen? Whenever we know that whenever there is an hyperviscosity, this leads to decreased cerebral blood flow. Decreased cerebral blood flow to the brain, there is decreased supply of glucose and amino acids to the brain, resulting in utilization. There will be increased cellular breakdown of red cell mass, resulting in hyperbilirubinemia. Hemodynamic effects of hypo or hypervolemia will be there. So hypervolemia will result in PCF, pulmonary edema, and cardiorespiratory failure. Hypovolemia, they result in hypoxic ischemic injury to vital organs. So polycythemia, complications are due to metabolic and hemodynamic effects of hyperviscosity. Microcirculatory perfusion will be deranged. There will be decreased organ blood flow, multicellular MODS, and there will be increased destruction of erythrocyte mass along with hyper or hypovolemia. So resulting in tissue hypoxia, acidosis, hypoglycemia, and regional effects of hyperviscosity. Hypoglycemia. Hyperviscosity will lead to decreased cerebral blood flow. This resulting in decreased glucose carrying capacity, decreased plasma glucose concentration, and there will be decreased utilization of glucose in the brain, resulting in hypoglycemia. Hypocalcemia. What is the reason? The level of calcitonin gene related peptide, that is CGRP gene, increases in polycythemia. They regulate vascular tone in stimulating vasodilatation, resulting in hypocalcemia. Then what is the cause for relative thrombocytopenia? See, it is not thrombocytopenia, it is a relative thrombocytopenia. The density of erythrocyte increases in polycythemia, where the erythrocytes accumulates in the center of the blood flow and thrombocytes are lighter. They migrate to the periphery of the vascular wall. So they result in thrombocytopenia. Actually, there is no thrombocytopenia. So what are the complications? What are the effects? Most of them are asymptomatic, like 74 to 90%. And symptomatic, they affect mainly many organs and systems. So what are the clinical signs are mainly because of hyperviscosity, decreased tissue perfusion, metabolic complications like hypoglycemia and hypocalcemia. What are the non-specific signs? Most of the children will be missed. They can present with apnea, they can present with cyanosis, feeding problems, vomiting, irritability, lethargy, tremors, respiratory distress, seizures, jitteriness. The most common is the problem is CNS disorders, which they present with polycythemia. So what are the cardiorespiratory problems? They present with cyanosis, tachypnea, heart murmur, CCF, cardiomegaly, increased pulmonary vascular resistance, and prominent vascular marking on chest. Renal, they present with decreased GFR, decreased sodium excretion, renal vein thrombosis, hematuria, proteinuria, oligouria. Others, they present with thrombocytopenia, poor feeding, jaundice, persistent hypoglycemia, hypocalcemia, testicular infarcts, priapism, DIs. So how to get it done? Lab diagnosis. Routine screening, is it necessary? No, they are not necessary in asymptomatics. Only if there is a high risk groups, we have to get a routine screening done. What are high risk groups? IUGR, large for gestational age, IDM mother, monochorionic twin. So in these children, we usually do screening. It can be measured by venous, also capillary. So which is better, venous sample or capillary sample? Always venous sample is better because capillary sample, they have higher value. Why is that? There will be relax formation and migration of erythrocytes along the vascular wall and sensitive to, then they are sensitive to variations in the blood flow. Therefore, capillary show high values than venous. So gold standard is venous blood sample. In general, hematocrit level in capillary is 5 to 15% higher than in venous sample. So peripheral blood hematocrit is higher than central blood. So in a study conducted on newborns, which involved peripheral venous hematocrit, which was more than 65%. So the three things were used: one is capillary, peripheral venous, or central. So venous hematocrit levels were reported where if it is a capillary, it is 75%, peripheral venous is 71%, and central venous, it is 63% respectively. So capillary versus venous. Capillary easy to collect, high values good for screening. The venous requires skill, comparatively lower values, which is a confirmatory test. How do you treat this? In clinical practice, most commonly encountered causes of polycythemia is dehydration. So if the child comes to us with polycythemia, we should always look for dehydration also. We should look for fever, we should look for feeding problems, we should look for diarrhea, we should look for vomiting, because they may mimic as polycythemia. So the initial 2 to 3 days are very important. So birth weight and then actual weight has to be checked. If it is the loss, if there is a loss of weight or more than 7%, that means there is dehydration which is going on. In case of dehydration, give more of fluid and then hematocrit. We should measure the hematocrit later and see. So all polycythemic newborn should be followed for neurologic, GIT, cardiopulmonary signs, and common complications such as hypoglycemia and hyperbilirubinemia. So we'll go diagram, we'll split and see. Okay, first capillary hematocrit. So confirm with which is high, more than 75%. So confirm with venous hematocrit. What are the investigations to follow? 1, look for dehydration. Weight loss, check for weight loss. If it is more than 7%, that means there is dehydration. Check for maternal history such as preeclampsia, diabetes. Look for delayed cord clamping, uncontrolled or precipitous delivery, etc. Presence of symptoms that might be associated with polycythemia like cyanosis, tachypnea, poor feeding or vomiting. Look for macrosomia or some symptoms suggestive of endocrine abnormalities. So measure and monitor blood glucose. Now you have confirmed. Now whether they are symptomatic, asymptomatic, that is very, very important. Now if they are asymptomatic and capillary hematocrit is 65 to 70%, don't do anything, observe. If the hematocrit is more than 70%, then what are the treatment options you have? Observe or observe with intravenous hydration, or if the hematocrit crosses more than 75%, then go ahead and do partial exchange. Now if they are symptomatic, then partial exchange you have to do. So observe closely with first give intravenous hydration. If it is not subsiding, go ahead with tea. If the symptoms are worsening, we should exclude causes of symptoms other than polycythemia, including pneumonia, cardiovascular abnormalities, and neurologic disorders. Partial exchange. So it reduces hematocrit without causing hypovolemia. It reverses physiological abnormality associated with polycythemia, that is hyperviscosity syndromes. Improves capillary perfusion, improves cerebral blood flow and cardiac functions. So, lot of evidence, lot of studies have been done regarding this partial exchange, and it was found that there is no effect on neonatal mortality, no difference in developmental delay. There is increased risk of NEC in infant receiving partial exchange transfusion. So no differences in short-term complication, including hypoglycemia. The two studies and polycythemia and one study. So as such, it doesn't have much effect. So it can be performed via central or peripheral route. In peripheral route, you can use both artery and as well as vein, and blood is removed from the artery and normal saline is infused to the peripheral vein, or in central route, blood is removed from the UVC and once again the saline is infused into peripheral vein or UVC and once again infused into UVC. So what is the how much to exchange? This is very, very important. This is a formula for the amount of blood to be removed in partial exchange transfusion. That is observed hematocrit minus desired hematocrit over observed hematocrit into blood volume. So now desired hematocrit is usually 55%, and the blood volume in a newborn in term it is 80 to 90 ml per kilo, and the preterm babies it is 90 to 100 ml per kilo. In general, exchange volume is 15 to 20 ml per kilo. So which fluids to use? It is crystalloids such as normal saline or ringer lactate, or colloids such as fresh frozen plasma or 5% albumin can be used for PET. But choice, what is the choice means? It is normal saline. Very, very important. Why only crystalloids, that is normal saline or RL? One, it reduces hematocrit comparably, and second, there is no transfusion associated risk of infection. So these are different trials, clinical trials and partial exchange transfusion done in neonates with polycythemia. Now what is the prognosis? Polycythemic babies assessed early by Brazelton Behavioral Assessment Scale demonstrated abnormalities of hypotonia, poor state control and irritability. So if you look back and see what happens to the long-term neurodevelopment, so many studies have been done regarding this, and there were no neurodevelopmental difference between polycythemia and normal infants at 8 months of age. But on subsequently at 2 years of age, there was speech, hand, fine motor abnormalities was noted. And same children
Kumar?
at 7 years. Sir.
Kumar?
Sir.
Can you finish fast, because
finish.
Already 7 o'clock, because there is one more talk, dear.
Okay, sir, finished. And the long-term effects of partial exchange transfusion neurodevelopmental outcome, so there is no long-term benefits. That's what they say. So the same thing. Now, what are the recommendations? Routine screening for polycythemia is not recommended. Routine performance of partial exchange transfusion in asymptomatic is not recommended. Screening for symptoms should be performed carefully and documented in all infants with polycythemia. Normality of blood glucose should be documented in all infants found to have polycythemia. Partial exchange causes a prompt relief of symptoms. The presence of symptoms on or of hypoglycemia should lead to perform partial exchange. PET should be performed as early as possible whenever symptoms are present in view of potential for more severe symptoms and complications to develop. If performed, should be done with normal saline. So conclusion, PCT is a venous hematocrit of more than, polycythemia is a venous hematocrit of more than 65% and is likely to be significant in infant more than 6 hours. Symptoms or complications of polycythemia are unlikely to be related to hematocrit of less than 65%. Always measure venous hematocrit. Look for dehydration before the diagnosis. Partial exchange with normal saline peripheral route is preferred and it is cost effective. There is no evidence that partial exchange alters the neurologic or developmental outcomes of asymptomatic polycythemic neonates. Thank you.
Thank you, Dr. Kumar. Excellent talk. Okay,
Thank you.
more elaborative. Very good. Thank you.
Thank you, sir. Thank
So can I ask the next speaker, Dr. Vishwanath?
Yeah, I'm here.
Dr. Vishwanath Kamoji?
Yeah, I'm here.
Yeah. Okay, sir. Please
Kumar,
take these things.
can you remove? Can you?
Kumar, can
I
you
removed, sir.
please?
I
can you
removed.
stop?
Yeah, yeah.
Remote. Okay, Kamoji, you please.
Just start sharing. Start sharing. It will ask you say, start sharing your slide. Automatically, it will stop.
It'll stop, is it? Okay.
Yeah, start.
It doesn't say show.
Yeah,
It doesn't say. Yeah, okay.
able to see.
Yeah, welcome to Dr. Vishwanath. Please go ahead.
Thank you very much, NNF Karnataka, for giving this opportunity for doing this webinar. It's been some time now, and I would like to rush through my slides. And please, if somebody can ping at the end of 30 minutes so that we can finish at least on time.
Yeah.
It's good to put on Karl Landsteiner's photograph in the first slide, who has been the father of ABO blood group, who detected these blood groups about 120 years back. What is unique about neonates? We have heard Dr. Kumar speak volumes about the blood transfusion. In brief, we have higher volume per weight, there is phlebotomy losses, immature immune system, variation of blood volume with age, reduced erythropoiesis, reduced effect of erythropoietin, physiological anemia, maternal antibodies, reduced RBC survival, and cardiovascular adaptive capacity is low. The age-related development immaturity, including hepatic, neurologic, and immune systems, make them more vulnerable to organ injury and metabolic complications associated with transfusions. At least 50% of the preterms less than 30 weeks and nearly 80% of those less than a kg will receive some blood or blood product transfusion during the stay in the NICU. And estimates of overall prevalence of neonatal thrombocytopenia vary from 1 to 5% of all neonates and is averaged about quarter among neonates admitted to neonates in the NICU. As a generalization, the levels of evidence underpinning recommendations on safety and effectiveness of platelet and plasma transfusion to neonates are far less clear than for red cells, which means there is more robust clinical evidence available for red cell transfusion than for platelets and plasma cryo. This sentence or this quote was by Dean Ferguson in Edinburgh, and it was more for adults, and it holds very true for neonates as well. The overview of presentation is going to be general and technical considerations. Transfusions, why, what, when, and evidence of for cryoprecipitate, FFP, platelet concentrate, packed cells in that order, and a brief touch on immunoglobulin. Finally, what Dr. Kumar has also touched on, means of reducing the transfusions. Blood banking and technicalities. All pediatric and neonatal blood is available is obtained from adult blood, which is added with citrate. It is spun to separate the RBC and supernatant of plasma and WBCs. These WBCs are then reduced to form RBC with leuko-reduced RBCs. Of this, the plasma is removed. And if this plasma is frozen within 8 hours, it is called fresh frozen plasma. And if it is frozen by 24 hours, it is called just a frozen plasma. Now you have the RBCs with high hematocrit because all the plasma and the WBCs and the platelets are removed. To this is added some solution to get a hematocrit of approximately 55 to 60%. And of these adult pack, 6 to 8 pediatric pack, or also called petty packs of 40 to 60 ml is made, especially in the Western world. And we can also do it in India. And this is to reduce the number of donors for transfusion per neonate, as was alluded by Dr. Kumar in his slides. Now, the removal of plasma and addition of solution includes CPD, which is citrate phosphate dextrose. which is citrate phosphate disclosed as anticoagulation, along with adenine and mannitol, which act as preservative. And all these help to stabilize the RBC membrane, provide ATP and energy for RBCs to be maintained for at least 35 to 42 days for pediatrics and adults. These also act as buffers to maintain a not neutral pH in the blood. The removal of the plasma has implications because it also removes the major iron-binding proteins and extracellular antioxidants from the final preparation. And this actually builds up the redox active iron in the extracellular medium, leading to iron-mediated oxidative damage to the RBCs, which may induce many other iron-mediated oxidative damage to the baby post-transfusion. We know of ROP and necrotizing enterocolitis, etc. The blood so obtained must be maintained in a cold chain from collection to transfusion. And the donated whole blood is transported at 20 to 24 degrees for maximum of 6 hours. It is separated into components: red cells, plasma component, and platelets. Red cells are maintained between 2 to 6 degrees all throughout before it is sent off for the recipient, where it is thawed to the normal room temperature. Plasma component, which includes plasma and cryo, is frozen to minus 30 degrees or lower, and it is transported around that age to be thawed before transfusion. Platelet is maintained between 20 to 24 degrees centigrade, and it is constantly agitated because you do not want any clumps which will waste the platelets. This is then reaching the recipient in that condition to be thawed to the normal temperature. There are some general principles of transfusion, and I'm not talking of ABO compatibility or RH compatibility. It is to do with two main things: communication and documentation. The communication is to do with the parents. They need to understand what is the reason for transfusion and what we anticipate after transfusion. The communication should also be with the blood bank, not just for the type of product needed, but also if an O negative blood was used for it to be replaced, and colleagues, so that the nurses understand, the junior doctors understand, and the handover happens effectively. What we have communicated has to be documented, that we have communicated with the parents, consent has been taken, the details of RBC or platelet plasma transfusion with indications, and more importantly, the response to transfusion, whether the child has been well or has developed any side effects of transfusion, must be documented. Sampling is extremely important, and sampling problems create a lot of issues in the neonatal unit, and these are common to have, especially coagulation disorders being misplaced. Coagulation is very important with an arterial line because it is heparinized, and you need to take sufficient sample of blood out before you get a clear non-heparinized blood, which must be used for the coagulation sample. The volume must be accurate because otherwise it is wasted if it is high or low sampling. If there is high hematocrit, it can affect coagulation sample. It can affect the platelet numbers as well as the hemoglobin as well. The platelet and hemoglobins are also affected by small fibrin thrombi being formed in the vacutainus. So you have to constantly agitate them so that there are no blood clots formed in the samples. Platelet count is also affected by whether it is a manual looking into the person, pathologist looking into the slide, or a machine count, because a machine will pick up a fewer number of platelets if they are coalesced and there are megakaryocytes, big megakaryocytes. So you'll get a false reading of platelets. Let's go to FFP and cryoprecipitate. The neonatal coagulation system matures slowly after birth, and depending on the level of various factors at birth, the normal reference ranges neonates and infants are quite different from those in adults. If you look at the analysis of coagulation tests on day 1 of life, there are 3 subcategories: A, less than 28 to more than 28 weeks, B, small for gestation age and appropriate gestation age, and C, with preeclampsia or help and no preeclampsia help. If you look at the PT and PTT, they are all wildly different at 28 to more than 28 weeks, small for gestation age to more than appropriate gestation age. Also, the reference values for intervention of the PTT for PT and APTT in term and preterm different is different from babies born at term, babies born preterm 28 to 34 weeks, and babies born extremely preterm less than 28 weeks. Further, if you look at the values per day, day 1, the values are different, day 5, the values are different, and day 30, the values are again different. So that creates a lot of ambiguity in what values we should be taking to treat babies who have some kind of a disorder. It is known that very immature infants have low levels of most clotting factors and may have prolonged clotting times. Correction of these prolonged clotting times using FFP in the absence of clinically significant bleeding has not been shown to reduce the risk of IVH or other bleeding. Therefore, routine estimation of coagulation in otherwise preterm infants is not recommended. So when do you actually do a coagulation profile? Remember, we need sufficient volume of blood and it must be taken correctly, otherwise it will be discarded. HI, when you're cooling the baby and when you're warming up, you need to do the coagulation test, pre-exchange transfusion, and clinically, if the baby is extensively bruised, is definitely bleeding, septic DIC has thrombocytopenia or necrotizing enterocolitis. Finally, if there's a family history of coagulation disorders, it must be done. To tell how difficult it is, highlight how difficult it is to interpret the coagulation numbers, I present a case which we had a couple of days back. This is a 3-week-old term baby who was referred from Andhra Pradesh, distant place, with this amount of bruise noted on the day of admission. The story was that this baby had fever ongoing for the past 7 days and was on paracetamol and mefenamic acid alone for them. And the day the baby presented, he had been to a doctor who noted these bruise and thinking the baby may also have more bleeding, especially in the brain, rightly so, referred to the higher center. This is a bruise quite significant. Interestingly, also, the parents mentioned that there is a consanguinity in the marriage. The cord had fallen off a couple of about 7 days back, and it was still oozing. This baby had coagulation screen done locally, which was normal, and it was difficult to believe that it was normal. So we did the coagulation screen with us again, and lo and behold, it was normal. So this baby presented quite late in the night, 2 o'clock, 3 o'clock in the morning, and we discussed this with the hematologist, who suggested we do a further screen of the bloods which we had taken in a specialist lab. And when we got it done in specialist lab, we found that the APTT was prolonged, the PT was normal. And we had sent for factor 13 level, von Willebrand factor, and fibrinogen, and we are waiting for them to come back. So this shows how difficult it is to believe or to see a clinical state of the baby and non-matching numbers in the coagulation. FFP and cryo, as we talked about, FFP contains all clotting factors, albumin, immunoglobulin, and factor 8 at least 70% of normal fresh plasma. And cryoprecipitate contains mainly fibrinogen, but also factor 13, von Willebrand factor, and factor 8. The dose is 10 to 20 milligram per kg, generally over 1 hour for FFP, and you can go up to 20 ml per kg of cryoprecipitate, but generally it is a lower volume of transfusion. So what are the recommendations of FFP transfusion? As I mentioned, there is no prophylactic use of plasma, but for therapeutic use, when there is an active bleeding or concurrent to invasive procedures in patients at high risk of bleeding, those recognized to have an abnormal coagulation profile, which also includes DIC, liver failure, spontaneous bruises, vitamin K dependent bleeding, and to reconstitute whole blood for extreme transfusion. So what is an abnormal coagulation profile? As I mentioned, it is quite different in different babies. It must be more than 1.5 times midpoint of the gestational age and the postnatal age, which generally corresponds to INR of 1.5 or greater, APTT of 60 seconds or greater in terms and 80 seconds in preterm. Fibrinogen less than 1 gram%, and presence of FDP and D dimers. Importantly, the FDPs and D dimers, when you look at the neonatal unit, neonatal numbers, you don't see a lot of these suggesting that we do FDP and D dimers. What are the recommendations for cryoprecipitate transfusion? Cryo is specifically reserved for specific factor deficiency when the factor is unavailable. Congenital or acquired hyperfibrinogenemia remains the most important recommendation, along with factor 13 deficiency, von Willebrand deficiency, and factor 8 deficiency. It is also given when the bleeding is uncontrolled after giving FFP. There are some special situations where these products can be used, especially cardiopulmonary bypass surgery, ECMO, and neonatal thrombosis. Let's look at the platelets. As with FFP and cryoprecipitate, there is not much of evidence of platelet transfusion for babies who remain stable but have slightly low platelet counts. Obviously, there is no question of treating a bleeding baby who also has low platelets. The most premature of the infants have the highest risk of developing thrombocytopenia, and platelets remain the second most commonly transfused blood product in neonates next to RBCs. There are many classifications of thrombocytopenia, but I feel this is a good classification, clinically relevant, where you classify thrombocytopenia into early onset and late onset. Early onsets are generally mild to moderate. Platelets do not drop significantly. It evolves slowly over days and is associated with complications of pregnancy and may not need any treatment. The late are generally severe. Platelets drop quite rapidly and progressively over 24 to 48 hours and is associated generally with more serious conditions like sepsis, neck, and may need multiple platelet transfusions. But the clinical issues are age-varying thresholds of thrombocytopenia in neonates, and we need to establish the severity of thrombocytopenia and the relevance or consequence of that in relation to bleeding and hemorrhage. We should have validated tools to assess the bleeding in neonates, and there must be transfusion thresholds and guidelines for stable and ill neonates. There have been many studies done. One of them done in quite old 1993 was effectiveness of prophylactic platelet transfusion, where they looked at moderate thrombocytopenia defined as 50 to 150 raised to 9. It showed that it was not detrimental to short-term neonatal outcome, specifically to prevent the risk of progression of IVH, PVH. Subsequently, Stanworth did a prospective observational study for less than 60, and again, they did not show any difference because of prophylactic ones. And Muthukumar in 2012 clearly mentioned that there's no evidence of relationship between platelet count and occurrence of major hemorrhage. In all these things came this article in January of 2019 and from London, Oxford, and Cambridge. And he's one of our colleagues who may be listening to this, and I had discussed with him last week about the platelets. It's Dr. Vidya Venkatesh. It's a randomized trial of platelet transfusion thresholds in neonates, also called PLANET 1 and 2 studies. They randomized infants born at less than 34 weeks of gestation in whom severe thrombocytopenia developed to receive a platelet transfusion, at a threshold of 50,000 per cubic millimeter, which they call as high threshold, or 25,000 per cubic millimeter, which they call a low threshold. Bleeding was documented prospectively with the use of validated bleeding. It's a validated bleeding assessment tool, as I mentioned, and the primary outcome was death or new major bleeding within 28 days after randomization. That's a randomization. I'll skip that. Coming to this graph, which showed patients who survived without major bleeding to trial day 28 according to treatment group. If you look at the chart in the first 6 to 7 days, there is hardly any difference between low threshold group and high threshold group, but it widens as the days go by, and there's a significant difference at the age of 28. The low threshold group, there are less number of deaths, and in high threshold group, there are more number of deaths. So in conclusion, they say among preterm infants with severe thrombocytopenia, those randomly assigned to receive platelet at a threshold of 50,000 per cubic millimeter had significantly higher rate of death or major bleeding within 28 days of randomization than those who received platelet transfusion at a platelet threshold of 25,000 per cubic millimeters. They also mentioned that most transfusions through the world, including England, were given prophylactically, and there is no evidence it reduces IVH. And this trial shows definitely higher morbidity and mortality for treatment threshold of 50,000 K. But that extrapolates to the next question. Can we actually wait for the platelet to fall to 25,000 and see what happens if the baby is entirely, completely normal and is stable? It is quite difficult in clinical practice to hold the nerve and not do anything if the platelets have dropped to 25,000. Surgical babies, clearly, they need a little bit more platelets for surgery, and for lumbar puncture and line threshold, though they have not mentioned, it is reasonable to have a fairly high platelet count before we do all these. So the recommendation on the basis of all that is clearly divided into non-bleeding neonate, bleeding neonate, and neonatal alloimmune thrombocytopenia. I'm not touching too much on NAIT because it's been discussed yesterday. NAIT patients or babies actually bleed much more than non-NAITs with the same platelet levels. So they must be transfused if the platelet levels are less than 100 at any levels. And bleeding neonate, at any level, you need to transfuse. But importantly, with a non-bleeding neonate, you do not need to transfuse if the platelets are above 50,000. And you consider transfusion in all non-bleeding units if there's less than 30,000. And between 30 and 50, consider if the baby is less than a kg, less than a week old, clinically unstable, they had a major bleeding in the past, their current minor bleeding, concurrent coagulopathy, or the baby needs surgery or exchange transfusion. How much? 10 to 20 ml per kg over an hour. Let's go to packed red cells. I think Dr. Kumar has touched a lot on red cell transfusions, but I shall be quick with my presentation. There are some technical terms. Pedipacks we have discussed, leukoreduced he has discussed, and it is proven to reduce febrile non-hemolytic transfusion reactions. It definitely reduces CMV transfusions and HLA immunizations. Whether it reduces the transmission of infection and other organ infection is query of benefit. Irradiation has always been touched, and it is proven to reduce graft versus host disease. And because there is a lot of potassium leak, it has a reduced shelf life. These irradiated cells should be used within 14 days and cannot be extended any longer. The irradiated bloods of platelets should be used for top-up transfusion of after intrauterine transfusion, preferable for all exchanges, and transfusion of blood components for first, secondary relative, proven or suspected congenital T-cell related immunodeficiencies. Having said that, there are some indications where the baby will need immediate transfusion at birth. The indications might be fetal-maternal transfusion or hemorrhage, chin-to-chin transfusion hemorrhage, placental causes like abruption, vasa previa, accidental cord rupture, and sometimes the baby has such a massive subgaleal hemorrhage that we need to transfuse at birth itself. For that, you need to have O-negative blood standby at all times in OT and in the leg rooms. It is an O-negative blood because it can be given fairly quickly. It is leukodepleted and hence CMV negative. It must also be hepatitis E negative. It is important to take a blood sample from the baby prior to emergency transfusion for blood group, count, hemoglobin, coagulation, and also save some blood for future investigations. Once you use that O-negative blood from the fridge, you must inform the blood bank of its use so that it can be replaced. What are the factors to consider for transfusion? There are age-specific definitions of anemia. What are the liberal and restrictive strategies? The age of stored RBCs and adverse effects in preterms, and correlation of RBC transfused mass and improved oxygen in units. Dr. Kumar has touched on all this. I will quickly run through that again. If you look at the different randomized trials for RBC transfusions, they have all used different thresholds, whether it is restrictive or liberal. And that indicates worldwide there is no specific hemoglobin which we can hang on to and say, well, this is a hemoglobin and we should do something about it. Also, if you look at the hemoglobin where transfusion in newborns has been done, it is quite different, which includes British guideline, American Red Cross practice guideline, Australian or Canadian. Anemia in the first 24 hours, infants receiving intensive care, severe cardiopulmonary diseases, CPAP on oxygen, late anemia, stable patients. You see the hemoglobin is different. American Red Cross is all about hematocrit. Australian differs from Canadian, and that is what we are. This is because hemoglobin is taken as a surrogate marker of oxygen delivery. So until we have a much more robust marker of oxygen delivery, we will end up using hemoglobin and hematocrit as these surrogate markers. I'll skip through these studies. There is practically many studies for hemoglobin thresholds, whether restrictive or liberal. Now, what restricted and liberal means that you do not transfuse till the hemoglobin drops down to some degree of low levels is called restrictive. And if you wish to keep the hemoglobin at a much higher level, that's called as a liberal transfusion. So many studies have been done, and that has not shown a lot of difference. And not just individual studies, there have been systemic reviews about these transfusions. And again, it does not show any difference of increased mortality, morbidity, chronic lung disease, or any other significant long-term effect. What are the potential benefits? The proposed benefits of this transfusion is derived from enhanced systemic oxygen transport, as you will all know. This includes prevention of apneas and promotion of weight gain. But there are also studies which do not show these benefits at all. What about the other evidence? Levels of evidence from RCTs for the safety and effectiveness of different storage solutions are limited in neonates. Fresh versus old blood transfusion, Cochrane, it shows no evidence of benefit, and some studies quoted by Dr. Kumar also shows no evidence of any benefit. But the exchange transfusion definitely needs some amount of thinking in regard to this one, and that needs fresh blood transfusion. So these are the suggested thresholds or recommendation for preterm neonates for transfusion. If you look at this chart, it divides babies into ventilated, needing some support like oxygen, NIPPV, or the baby is being stable off oxygen in the first 24 hours, first week, second week, and third week. And as you see, the ventilated babies definitely need to be having higher hemoglobin. So the threshold is slightly higher compared to those babies who are completely stable. And as the weeks go by, even the ventilated babies, we can have restricted transfusion policies. How much and how long to transfuse for? There are a lot of formula-based calculations, but the commonest one is weight times the aimed minus current hemoglobin, or how much hemoglobin you want it to rise by the transfusion factor, which is usually 3 or 4. And it's not evidence-based, but there are plenty of them floating around, and you will have one of them when you're working in the neonatal unit. For example, if you have a 1.5 kg baby with a current hemoglobin of 8 grams, and you want to increase to 12 to 13 grams, depending on what you want to increase, 12 or 13, the volume comes to 24 to 30 ml. It's generally between 15 to 20 ml per kg. Take the higher value so that you do not transfuse them again and again. The transfusion should be done over 4 hours and rarely faster. When you do this, you need to factor in feeding, growth, and infection. Finally, coming on to reducing infections, which has been again touched on. Why do we need to reduce the transfusions? Because there are risks of infections or complications and Jehovah's Witness. We don't see a lot of Jehovah's Witness, but we had a discussion about it recently from one of our colleagues. They do not accept any blood and blood products. We also have the Jehovah's Witness in India and not just in the West. How it is done at birth by delayed cord clamping, cord milking, and taking a cord blood sample in extreme preterm and extremely low birth weight babies, so that that volume of blood is not drawn from the baby. In the NICU, you rationalize investigations. I talked about the arterial line sampling. Point of care investigation definitely reduces the bloodletting, and erythropoietin can be used, but it's fallen out of fashion at this moment because of side effects. Pre-surgery autologous transfusion is recommended, but how often do we do that in the neonatal unit? I'm not aware of. At least in my experience, I've not done it in the last 10-15 years. Any transfusion topic is not complete without discussing the serious hazards of transfusion or transfusion reactions. This can be acute or delayed. This can be immunologic or non-immunologic, and hemolytic, non-hemolytic, allergic, and transfusion-related acute lung injury. Along with that, we also have TANIC, which is transfusion-associated necrotizing enterocolitis, which is a known entity now, and that must be considered when we are transfusing babies who are at a certain age and who need transfusion. Finally, one of the blood products is immunoglobulins, and so I have included that in the talk as well. Immunoglobulins are produced from the adult blood, and its uses are generally for Rh negative mother in the prevention of antibodies that can result from fetal-maternal hemorrhage, and it is indicated after delivery or pregnancy loss if baby is Rh positive. To treat Rh incompatible neonatal jaundice before contemplating exchange transfusion, to treat idiopathic thrombocytopenic purpura, and as post-exposure prophylaxis for a number of diseases if specific immunoglobulin is not available. For example, hepatitis B, varicella zoster, and all that thing. And that ends my topic of transfusion of blood and blood products, and I pass on to the moderator to take any questions he may have, and we shall discuss. Hello.
Yeah. Thank you very much, Dr. Vishwanath.
Yeah, Dr.
Sir.
Prashant.
Over to you, sir.
Excellent. Yeah, Vishwanath, excellent talk. Prashant, can you just keep on asking questions? Just I got one call from ICU. I am going to ICU. Can you just continue, please? I'll take over from you.
Okay, sir. Okay.
Okay, please.
This is for Dr. Mirji. What is the role of low-dose aspirin in treatment of neonatal venous or intracardiac thrombosis? If thrombus is less than 50% of the rate. Can you hear me? Mirji.
Yes, yes.
Yeah, it's for you. What is the role of low dose aspirin in the treatment of neonatal venous or intracardiac thrombosis? The thrombus less than 50% of the right atrial size.
Regarding aspirin, they're not as much studies. Actually, they are given in perinatal stroke rather than the thrombosis. The low molecular heparin or sometimes warfarin they will give, not as a aspirin, especially perinatal stroke, which is not I not mentioned in this because of short time.
Okay. Okay, so there is one more question for Dr. Kumar. How partial extent transfusion increase the risk of NEC, as polycythemia itself is a risk factor for NEC? Dr. Kumar? Dr. Kumar? There is one more question we'll take up once the Kumar joins, Dr. Kumar. Do practice stopping of feeds while giving PRBC transfusion? Dr. Vishwanath.
There is conflicting evidence about whether or not you stop feeding. Some do and some don't. If you ask personally, I have seen enough NEC TANX transfusion associated necrotizing enterocolitis, which has resulted in almost immediate death, severe necrotizing enterocolitis. So I tend to stop feeds when we are transfusing for 4 hours and 2 hours later on. And then when all is stable, we restart the babies on feeds. We don't stop for a very long time. It is just the transfusion time plus a couple of hours later on.
Okay, Dr. Srinath Manikanta has a question. Dr. Srinath, please go ahead.
Question to Vishu. Vishu, excellent talk. I want to ask you a couple of questions. Association of number of transfusions with ROP or PVL. And the second question is how quickly we can transfuse the platelets and how frequently we can do the platelet transfusion. Sometimes you do one platelet transfusion, again the platelets are low in severe cases, then how frequently we can do that?
I'll answer the second question first. If see, the platelet counts do not need to be raised if the baby is pretty stable.
No, we are
unless there is bleeding, you don't need to raise the platelet count because there are many indications or many reasons why the platelet count might be low. And if it is a stable baby, you give the platelets will still drop down. You need to treat the cause if there is sepsis or necrotizing enterocolitis, and you will see a rise in platelet count with all those measures. Repeat your first question again. I think I've answered your second question about platelets. Repeating.
The second question, how quickly you can transfuse the platelets?
Over how long? How many times? Or
no. Over how long?
Over how long?
Do it over 1 hour, right?
Yeah. It needs to be transfused. It needs to be transfused within an hour. It should not definitely be transfused over an hour because you'll start finding platelet clumps. If you can transfuse earlier, that is good, but definitely not over an hour.
30 minutes is acceptable? Because
30 minutes is very much acceptable. 30 minutes is very much acceptable. The idea is not to have any, because this needs to be agitated. These are platelets. These are procoagulants. So they will coagulate in the line itself. So you need to prevent that from happening. So transfuse as quickly as possible. 30 minutes to 60 minutes is quite a reasonable time.
And the first question I asked is, relation between number of blood transfusions the baby has and ROP or PVL.
ROP or?
PVL, periventricular leukomalacia.
Oh, PVL. Yes, there are definite studies which have shown that ROP and PVL can develop. But it is very difficult to tease out the other factors and relate only to the blood transfusion leading to ROP and the PVL. Can you hear that? There are some background noises. There are background noises there. Are you able to hear correctly?
I'm able to hear you. Yeah.
So when you have an ROP and a PVL, that means that the baby is so sick, so unwell, and so preterm. And ROP, PVL, chronic lung disease, and necrotizing enterocolitis. These are the 4 more important audit criteria we used to have, which suggest that these are multifactorial, and especially with such long story of neonatal care in the unit and such unwell baby, the baby will have one or the other morbidities. Yes, it has been seen that even a single transfusion can lead to ROP, but PVL has many other diverse reasons for them to develop, even without transfusion.
The reason I asked you the question is, we can have more preventive strategies by doing only capillary gases and maybe limiting the number of blood samples and probably starting iron early. So these are the interventions probably which can actually prevent number of transfusions.
There are a lot of developmental care. If you had listened to the talk yesterday, there are a lot of developmental care we can do to prevent these chronic and noxious stimuli which we do in the neonatal unit, and that itself will help with the neurodevelopmental outcome of these extremely small IUGR babies or babies who are even late preterms, which include number of tricks we give, the light, the sound, the ambience, the smell, and all those things.
Okay, thank you, Vish.
Prashant, regarding the question.
Kumar, please go ahead.
Regarding the question how the polycythemia itself is a risk factor for NEC, how this PET will cause the NEC. Actually, there were 2 studies done, and in that studies where the partial exchange was done, which by putting the umbilical catheter. So they had told that in the 2 studies also they have reported NEC as a complication. Whether the central line umbilical catheter causing it as NEC and the risk factor for doing a PET, is it because of PET? That's what is a question mark. So that still studies have to be done. But one complication is NEC, what they have said in the trial, in the report.
Okay, so we have, thank you, Dr. Kumar. Dr. Hemant Bharati.
Right. So my question to Dr. Vishwanath, that so in case of ABO incompatibility, can we use IVIG? And what is the role and how much is the dose? The dose is same as in RH negativity, or it's a different? And is there any specific IVIGs for this ABO incompatibility babies?
No, there's no specific IVIG. I can tell you that. It's just IVIG as normal IVIG. It's an important question because the immunoglobulins are used to reduce the antibodies of whatever types they are. And ABO incompatibility can lead to kernicterus and can be a reason for exchange transfusion. So by the time you are arranging for the blood, it is not unreasonable to try the immunoglobulin to reduce the load of these antibodies and hence reduce the hemolysis and the bilirubin level in that baby. The dose will be remaining the same. I don't think there's any difference in the use of IVIG in RH or ABO incompatibility.
But it is not a parallel management to the exchange.
Pardon me?
So it is not a parallel management to the exchange transmission.
It is to got a very high bilirubin, which needs exchange transfusion. You need the blood, and to arrange for the blood, it takes time. Till then, you give the IVIG, and if IVIG is working, you may actually discount doing exchange transfusion. If it is not helping, you still do the exchange transfusion.
Thank you.
Okay.
Dr. Prashant, is there any questions are still there? Because I got many questions from Facebook and other things.
Yeah. There are a few people who have raised their hands. Quickly, we can finish them, sir. Dr.
Okay.
Dr. Naresh? Yeah, please ask your question.
My question is, am I audible?
Yeah. Please go ahead.
If a newborn is diagnosed of hemorrhagic disease of newborn and has been transfused 20 ml per kg of blood transfusion given, and the child is still bleeding, then what to do and what amount of blood transfusion should be repeated and what precautions should be taken at that time? And question number 2, what is the incidence of neonatal thrombosis when we are using TPN or intralipid or even aminovan?
Dr. Kumar, you wish to answer this?
I did not understand the question. Once again, sir. What is the
incidence of neonatal thrombosis in cases of
okay.
TPN?
That's probably
MIRJI, sir.
That probably can be answered by Dr. MIRJI, but the first question about bleeding and blood transfusion, do you want to answer it? Vitamin K deficiency bleeding?
In case of bleeding, we have to get an assessment of PT, APTT done. See whether both are prolonged, prove it is vitamin K deficiency, given FFP. If there is significant anemia, then according to this one, 20 ml per kilo of PRBC transfusion has to be given. It is one transfusion per 24 hours.
Yeah, I agree with that, but the thing is, it's a vitamin K deficiency bleeding, and blood transfusion is not the choice of treatment there.
Vitamin K is a choice.
Vitamin K is needed, along with the clotting factor has to be sent, and that needs to be corrected. Yeah. Blood transfusion is to increase the level of hemoglobin and oxygen carrying capacity. That itself is not the primary treatment for vitamin K deficiency bleeding. Dr. Naren, is that reasonable response? Are you happy with that?
No, if the child is bleeding too much after receiving 20 ml per kg of the blood, if the baby is still bleeding profusely.
Yeah, so you give a dose of vitamin K, you find out what is the reason for that bleeding. Is it just vitamin K deficiency bleeding? The baby has thrombocytopenia, the baby has raised APT, PTTK or PT, and accordingly either give platelets or FFP. If bleeding still continued, you can try cryoprecipitate. Remember, the blood also contains a minor degree of plasma, but it is not sufficient to stop bleeding in those babies who need more plasma. So you might try vitamin K, either platelets or plasma, depending on what else is happening, and then transfuse that before you go for transfusing blood again.
Is there any role of hemostats in the cases of bleeding neonate? Hemostatic agent?
Yeah, locally you can apply epsilon aminocaproic acid, but systemically we haven't tried any of those in my experience. But in older children, definitely ESEA can be used even IV to be for all these bleeding manifestations.
Yeah, thank you, Dr. Naresh. Next is Dr. Sidhu has raised his hands. Dr. Sidhu.
Hi, good evening. I have two questions.
Good evening, please.
Yeah, well, I have two questions. One is for Kumar, role of erythropoietin in anemia of prematurity, and other one is role of double volume exchange transfusion versus IVIG in late onset sepsis.
Hi Sidhu, regarding this, I think we quoted studies also. There is no role of erythropoietin currently for preterm babies because of anemia of prematurity, because of complications. Even Cochrane has said that this erythropoietin cannot be used. Regarding the second question, what is that?
That was for Vishwanath sir. Double volume exchange transfusion versus IVIG in late onset sepsis. Because in parts of Karnataka, because of the cost constraints, hi sir, Sidhu here.
Hi,
because
Sidhu,
of the cost constraints, they go for double volume exchange transfusion, sir. Because IVIG itself will cost around 3,500 to 5,000.
Late onset sepsis and IVIG. Now, there was a study, INIS study, done worldwide, especially in England, which did not show any difference of using IVIG in septic babies. Full stop. Now, any septic baby who is so septic that he is not being controlled, you can do a couple of things. You can do plasma exchange or you can do double exchange. So it depends on what resources you have at hand. IVIG in late onset sepsis or neonatal sepsis is, I don't think anybody is using that nowadays.
Thank you. Thank you.
Okay.
Dr. Sidhu, Dr. Sahana ma'am has a question. Ma'am? Well, I'll just take a few. Yes, yes. Dr. Deepak?
Thanks, Prashant. Excellent talk, Vishu. It's about chicken pox. So as you know, we don't get.
We don't have VISIC.
So what is the dose of immunoglobulin in such babies? How much?
I think I had to look up instead of telling a wrong dose online to you. But IVIG is preferred if you don't have the specific immunoglobulin. We have hepatitis B immunoglobulin, but we don't have VISIC, and it needs to be looked at because we use it so infrequently. I cannot offhand recollect the dose. I'm extremely sorry for that.
No, that's fine. Thank you.
Yeah. Dr. Sahana ma'am.
Hello. Can you hear me, Prashant? Good evening.
Good evening, madam.
Yeah, good evening. All the three talks were excellent. One question regarding your transfusions, packed RBCs. We were talking about the small pedi packs.
Correct.
So difficult to get those things.
Correct.
Yeah. So how do we go about? Because we are invariably taking a lot of blood. We don't get the bags in all the places.
It's
the
difficult.
Bags, about 40 to 50 ml. Yeah.
It is difficult here, but it is quite commonly used in the Western countries.
Yeah,
I know. When I spoke about this to my my hematology team, what they say is they can actually transfer small amount of blood into smaller pouches and bag using sterile connecting device. The rest of the mother bag is retained and it can be used again and again because it's a closed circuit. So in a way, it does provide us pedi bags as well, because a mother bag is kept in a closed circuit and we can draw the required amount of blood from that bag. So this is,
that has to be, that has to be done in a blood bank, right?
That has to be done in a blood bank.
Yeah,
we cannot do it in the NICU or anywhere else. Because it's a closed circuit, it has to be done in the blood bank.
Okay, and role of FFP in sepsis?
Role of FFP in sepsis? Definitely, yes, if there is a abnormal coagulation, but otherwise we don't need to use as a plasma expander. You have much better and much cheaper products for plasma expansion. So you definitely don't use FFP for plasma expansion, but if the coagulation is abnormal, you must be able to use FFP. There's no question, no doubt about it.
Okay. Any role of FFP during your cooling, no? They'll have coagulopathy prophylaxis.
Yes, again, the cooling and especially the warming up stage can cause a lot of coagulation disturbance. And if there is a coagulation disturbance, it is one of the indications to use FFP, cryo, and even platelets at that time.
Okay. Thank you.
Thanks, madam.
Thank you. Thank
you. I hope that answers your question.
Yes, yes. Yeah.
Thank you, ma'am. Thank you, ma'am. Sir, sir, over to you.
Yes, excellent, excellent. If we will tell, all the things were very, very good, but I have received some more questions from Facebook. So, Dr. Prashant, I'll finish in very fast. It's a quick round. Dr. Gangadhar, are you there here? Gangadhar, okay, dear. It is for you once again. It is like a boomerang coming to you back. Warfarin, you told you we can use it in protein C and protein S deficiency you have treated.
Yes.
But they say that warfarin will also once again inhibits the protein C, protein S. So that is the reason there is some complication is there with the warfarin. How you have used? my dear?
No, we have monitor the PT-APTT. You maintain between 2.55 to 3 without any hemorrhage, and we supplemented the vitamin K at the same time because baby was on breast milk. It is having less vitamin K, so that's how it did.
So you mean is warfarin? Do you think commonly we do use warfarin?
No, it's not very much because patient was about to discharge because there no facility for subcutaneous enoxaparin. So baby was went for DAMA. So for that reason we used warfarin.
Yes, sir.
Very low
so
dose.
Carry home message according to you is in DIC or anything. Warfarin is not the first line of choice. Either low molecular or unfractionated heparin is the first choice.
Sir, low molecular weight heparin in thrombosis, sir.
Yeah,
in DIC,
it is the first.
no role. DIC is just treating underlying and blood substitutes. FFB or platelet depends on the which one is low.
Okay. So once again, Dr. Vishu, this thing. What is it, Dr. Gangadhar? Which heparin is better, unfractionated or low molecular heparin?
It is.
So in which heparin hit is very common in a neonate, even though which dose it will be very common.
As such, it is very, very less in neonate, but it is more with in neonate with heparin. It is unfractionated heparin. The chance is more compared to low molecular weight. And dose as such, if you go higher dose, like heparin more than 50, the chances are there. That's why I'm telling there is no such reports of severe thrombocytopenia or bleeding whenever using the heparin neonate. They are very well tolerated compared to adults.
Okay, so Gangadhar, there is one more thing for you, dear. So is there, what is that question they have asked? Is there any algorithmic approach for using the heparin, warfarin or unfractionated or FFP? Algorithmic approach incorporated with lab investigations.
I have to search and send it, sir. Because
yes,
all
sir.
that...
You know why I asked you, sir? No, Gangadhar, your talk was really excellent, dear. No, I am really, hats off to you,
yes, sir.
from
Thank
all
you
the
your
NNF
support.
members as well as participants. Really. So, excellent talk. That is the reason I asked. Because many people will talk on their own experience, or they will think, see what they read, what they hear, what they read something, what they will think something, what they will apply is something. If there is an algorithmic approach, see, this is the time I should give the FFP. This is the time I should use the heparin or unfractionated heparin. This time I should increase. So what is the laboratory to increase criteria?
Yes,
I
sir.
asked you.
Sir, it is there, sir. If we will do the anti-activated 10 factor levels. If it is if you are using unfraction, if it is more than 0.7, to increase that one will give FFB.
Just pause. But the algorithmic approach, if it would have been there, please share to NNF people.
Yes,
it will be very useful because I have not seen any algorithmic approach with the investigations, with the criteria.
Yes, but individually we have.
No, that is individual things. Many books will tell anything. See, what we read, what I think, what I do, we feel it is correct. But is there any printed algorithmic approach, investigational criteria? I asked you. Okay. So second thing, Kumar, you told capillary HCT is very high. Dr. Kumar?
Yes, sir. Yes, sir.
Capillary HCT usually come high.
Yes, sir.
But if anybody uses capillary blood gases for ABG, they will also take HB% because that is more better. HB percentage, if it comes, means automatically calculation will come HB. Do you think we should not take it more correctly then?
Yes, it should be. Actually, to diagnose as a polycythemia, it has to be venous blood. Capillary blood is not at all used. Gold standard is venous blood only. And
because
we know
many
that
readings are telling ABG HB percentage is also better. That is the reason I asked you.
That is only a false calculation. So hemoglobin into 3, what it gives is HCT. We don't use that. We have to get a venous PC hematocrit.
Yeah, if it is more than 65, better to use it.
Yes.
What you say? Yes, sir?
Yes.
Yeah. So, Dr. Vishwanath Kamoji, there are so many questions for Kumar. Please don't go away. Vishwanath? how long can we give platelets? So you told 4 hours. Okay. So if you are giving 4 hours, what is the method for a neonate you were going to give?
No, it's not platelets over 4 hours. Platelet has to be transfused within 30 to 60 minutes. It's a blood which needs to be given over 4 hours. And rarely we had to give blood fairly rapidly within 1 or 2 hours, depending on what is the clinical condition of the baby. If the baby is having severe bleeding, we end up giving it fairly rapidly rather than wait for 4 hours. With the platelets, we have to give much more quickly between 30 and 60 minutes. We don't wait.
Yeah.
To transfuse
Okay, sir.
platelets.
What is the methods? What is the method? What is the methods he has asked me? Probably what he is meaning is whether to use a syringe pump or whether to connect the pocket directly. What you want to me? How you are going to give, sir?
All neonatal blood or all neonatal transfusions are on a. Can you hear?
Yes,
please.
Yes.
So all neonatal transfusions are actually syringe pump driven. So you take that volume of blood and drive it through the syringe pump divided by 4 hours. You don't hang
divided
it.
by?
Divided by the number of hours. Divided by the number of hours you are giving. You're giving 40 ml of blood over 4 hours. You run at 10 ml per hour.
Platelets. No, I am asking you platelets.
No, you're confusing whether it is platelets or whether it is bloods.
No, it's a platelets. Question is platelets.
Platelet, all transfusions in neonates has to be driven by a syringe pump. So you have to drive it by syringe pump. If you have 1.5 kg, 2 kg baby times 10 or 15, 20 ml of platelets you have to give over an hour. Driven by syringe pump. You don't have to hang the on a pediatric pump.
Yeah. So Kumar, methods for partial saline exchange transfusion in polycythemia, which is more convenient, more feasible? It is from Andhra Pradesh.
Sir,
Dr. Kumar?
Yes, sir. Yes, sir. Are you hearing me, sir? More convenient, peripheral vein, give normal saline, and artery, you give draw the blood.
Sir, then he has also mentioned, sir, already because I have taught him, so he has sent a message to like this. Sir, you are putting the peripheral vein, slowly you are putting 2 peripheral lines, one in other limb, one in any other limb. In one limb, you are going to just keep on squeezing and collecting 5 ml. So you are giving another IV line.
No, wait.
Is it correct?
The saline should be pushed by peripheral vein. If it is an artery, easily you can draw the blood from the artery. Peripheral artery is also fine, or central umbilical vein is also fine.
Suppose if he puts the 2 peripheral IV lines, not artery, can he draw from one line? Can he push from one line?
No. He can do that, but peripheral line blood is not going to come. See, the amount of partial exchange will be a minimum of 15 to 20 ml per kilo. So around 30 to 40 ml, he cannot draw from peripheral vein. So it has to be one artery and one vein.
Okay, sir. Just it is for a discussion sake, not for any other, confronting sake.
No.
The only Kumar, because I am doing since 14 years with the peripheral IV line, drawing up to 40-50 ml blood, and every 5 ml I am pushing the blood. It is possible.
Okay.
It is possible. I am only doing. Just it is only a discussion sake. I am telling to my friend Kumar. No problem. Okay. There's one more question. Rarely we do see. 1 second. Wait. What is that question? Rarely we do see MCH and MCHC, MCB in neonate, and we ask because routinely it comes in the blood. But really, I have not seen MCH, MCB regularly. Is it really helpful in a neonate?
To diagnose what is the cause for anemia, MCV is 100% needed. We have showed a flow chart. Which MCV is a
neonate? Is it helpful, sir?
100%. MCV, based on MCV, we are going to draw next lines. The first is this one. The photograph, the photo showed, the approach showed. The first one, what we're going to use is a retic count. Then we get an MCV done peripheral smear. After the MCV, we do get a peripheral smear according to the protocol. So we have to follow MCV.
Okay, sir. Once again for Kumar, when we should do HB percentage or with HCT in IDM, IUGR baby, we know that there is some protocol is there for separate IDM and IUGR. Why that timeline is there, sir?
Sir,
It is from once again from Kerala.
Okay. Sir, initially what happens is based on, we have to rule out dehydration, we have to rule out weight loss, we have to rule out vomiting in the baby, feeding difficulties. So initially if there is weight loss, that means that can also precipitate to as polycythemia. So after 12 hours, it is very, very important. We should get a PCV done. Even if they are asymptomatic, if they are high risk children, please get venous PCV after 12 hours.
Okay, sir. Okay. I think so, Prashant. Dr. Prashu.
Yes, sir.
Okay,
Yes, sir.
All
Yes,
the
sir.
speakers have done a great job. One big round of applause.
One last question from Dr. Kumar Divakar has raised a hands. Dr. Divakar,
yes,
go ahead. Dr. Divakar. It's okay. Fine. Yes, sir. Yes, sir. I think.
Yeah. So Kumar, you are really elaborated the topic of anemia. Is one. Number two, Dr. Vishwanath Kamoji. Really nice topic, elaborated topic, very nice. And Gangadhar, today you are the crown. Excellent topic. Thank you, sir. For everybody, very good. Thank you. Over to Prashant.
Thank you so much. So I request all the participants to.
Tomorrow class.
After tomorrow, we have a class on Tuesday. So we will see you again then. Thank you very much. We'll see you on Tuesday. That is 26th. Bye bye. Take care. Have a good.
Thank you, sir. Thank you.